Yeah. Nigel, unanisikia? Likoko? Am I audible? Niko audible?
Yeah, nakusikia.
Yeah. Okay, nice. Yeah, so good evening, guys. Welcome to our space. We do have sometimes I do host healthcare spaces. We have discussed matters, what the issues that we face in healthcare. I think we have talked about last time I held a space on matters healthcare. We were talking about the interns issues. I think after our colleague had died by suicide, we were discussing about the issues that we face in healthcare. At that point was matters interns, HR issues, working conditions, toxic employers, and all those kind of things. So this is the second. This is now the subsequent space. We want to talk about healthcare. It's an interesting conversation because it's a people's space. We have Dr. Abdi Karibu. He's the chairman of SHA. I think he'll have a time to talk to us. And the reason why I held this space is because uh, I also happen to work in a mission hospital and in also public healthcare space, and we are having a lot of issues. The transition from NHIF to SHA. As a healthcare provider, also or in the business of healthcare, running a clinic here and there, I also have concerns. We also have issues with patients. Like the better part of the last 2 weeks, we have had issues with transitions, the system not working, and also we have the general attitude towards SHA SHIF. We have had reject, and those kind of conversations around the new scheme. Of course, there are also questions that regards there's a lot of money that is going around. You've heard of billions and billions. You've heard of Jayesh. You have heard of so many things that basically has created a certain attitude or perception towards this new scheme. And so that's why I sought for Doc, the chairman, to also come and perhaps raise, or rather give us tell us in detail what this is, answer some of your questions. And so it's an open space. We will allow healthcare practitioners, we'll allow patients to give us their experiences, we'll allow people who have opinions on how. I'm sure chairman he has been quite consistent and available in trying to raise clarity around this subject. And so ask those questions. I also, my only wish is that even when you're having the conversations, let's be respectful. We are trying to have answers to what we want, and also we are trying just to ensure that our healthcare system works, which has been quite a problem with this regime. To be welcome anyone who wants to speak. It's an open space. It's an open mic. We love Doc also tell us about this thing, what questions we have, what concerns we have. I love questions for him. If you have any questions, also you can comment on the space chat. We can pick it up. Any civilian who has a question, who has clarity, who has the experiences with the issues that you are facing, you're welcomed. I have my co-host, Dr. Nigel. Karibu, give us something before we allow Doc to say something. Nigel, or you have an opening space, or you can have the conversation going.
I think what I can say is that this space is actually is a nice thing, so that we can hear at least now from the chairman himself. So tell us about, especially now, the chief, and so that we can get clarity on some of the things that or some of the concerns that we may have about the the whole SHA and chief.
Yeah. So thanks. I think I'll give Chairman to give us his open remarks. I want him to tell us what this new scheme is, why the government felt it's the need to change the old system that we had to the new system. Why not have some improvisation on it before we come to what we feel, what we're experiencing in the ground, what our attitudes and opinions are, perhaps what our recommendations also are. Doc, karibu. Maybe you can confirm you can hear us and you can say something.
Yes, I can hear you loud and clear. Thank you very much, Madaktari, colleagues, my junior colleagues. When you requested, I told you I'm ready and available to clarify the issues. The reason is because there has been a lot of misinformation that has been going on. And I understand because generally trust is an issue that we have had. On that note, I thought it would be wise for me to just come in and explain some of the issues which are clearly not true, and then just lay bare what is the whole idea. So I, I, I I think people are aware that there were 4 laws that were passed, the UHC laws, October 19th, 2023. So the 4 laws, if you look at them, there is first one, which is the Facility Improvement Fund. The second one is the Primary Healthcare Act. The third one is the Digital Health Act. The fourth one is the Social Health Insurance Act. So I will just try to explain briefly what each one is meant to do. So the FIF, the Facility Improvement Act, was meant to ring fence healthcare money to the facilities. Currently, as it is, some counties have that law, some don't have. Some counties allow 30% of the money to remain in the facility, others 50, others 70, others 80, some a few 100%. So what we wanted to do is when facilities collect money from user fees or from NHIF or from whoever is paying, whether it's private insurance, they use that money to improve the facilities. And I'm talking about public facilities, so that that money is ring-fenced for health. So the idea of a facility generating, let's say, 100 million, and then it gives to the county government. It goes to the county, then it's the MCAs that decide how that money is going to be used, which sometimes they receive 20 million back or they receive nothing back, and that money is used for other purposes. For that reason, we said, let's have a law that makes it mandatory for all facilities to keep their money. So the law was passed in Senate, so that is mandatory now to all facilities. So the second thing is the public now just to make sure that they participate in running those facilities. The act also allows the community to be part of the health management team for level 2 and 3. They sit, and it has youth representative, it has women, it has like almost 6 seats are reserved for the community in the health management board for those facilities, level 2 and 3. And level 4, 5, I think they have one seat or something to that effect. So this is meant to keep money in healthcare. Budgetary allocation plus collection remains in the facility. There should be no excuse that the facility doesn't have healthcare workers, or no excuse for the facility not having money to buy drugs. Second act was the Primary Healthcare Act, which now introduces the issue of community health promoters. Previously, these guys were there, but they were run by NGOs, and they used to do small, in a county, they would go to one ward, and then they are paid a certain amount. They do one condition, and they carry big registries, books to record for one disease. So they were doing one activity in one place and nothing else. And guys used to collect millions of dollars outside the Kenya in the name of community health. So what we thought is the national government should be able to pay stipend to these people and have across all the 47 counties, across all the wards, and then give them phones digitally to be able to, that registry, instead of doing it manually, they collect the data through the phone, and there's an electronic community health information system that allows for them to record the necessary inputs. So some of the things that they find out is whether the children are malnourished. So they do MUAC, tape measure to measure the babies. They look at whether they are pregnant mothers. They ask whether they have gone for the clinic ANC. If they have not, they encourage them and link them to the nearest facility to go for the clinic to start. Then if they find people who have chronic conditions, hypertension, diabetes, they do random blood sugar just to check whether they are properly controlled. If not, they tell them to go to the facility. So their work is basically to assess and link. That's it. They don't treat anyone. They just make sure they educate the mothers on wash, in terms of the usual hand hygiene and all those things, so that the mothers understand on how to do prevention. So they are more on prevention and linkage to the facilities rather than treatment. Then the third act is the digital health. So the challenge we have had is we have paper. You can't run UHC on pieces of paper. It's impossible to have silos. Data is in different systems, in different books, in different registries. So the ministry is not able to plan, the county is not able to plan because we don't know our disease burden, how big it is. We have had what we call Kenya Demographic Health Survey, which happens every 10 years. So every 10 years means one government starts its term, and then the assessment is done when it's exiting. So that government has no information on how utilization, ANC coverage, family planning, skilled delivery for mothers. They don't have all that information. That information comes out after 10 years. So new government finds the scorecard of the previous government. Then they remain in the dark for 10 years. When they're exiting, there will be another scorecard. So because of such things and because of duplications and data which you don't have a way to provide policy direction, where do you need to invest? How much do you need to invest? We have never known because of the manual system that we are operating on and the silos. So you will find a patient walks into this facility, they walk back to the nearest facility, that patient repeats all the tests because he hasn't carried his results. So the other hospital says, we don't know whether you have been tested or not, so we are repeating the tests. For that reason, we said, and the Health Act of 2017 also says the same, digitalize and connect. So now what we are doing is connecting all public health facilities, all private facilities, all pharmacy outlets and standalone laboratories. And then you have client registry, you have facility registry, which has a single source of truth. Then you have all healthcare workers. So we have a lot of quacks in the health industry. Unfortunately, that is people take advantage. And then we have a lot of healthcare workers who are unemployed. So you have a mismatch. There are quacks in the system who are operating nicely, making money. Then you have young, skilled workers who have gone through the system and licensed not getting jobs. So now you cannot be able to work and see patients if you are not licensed, because it's the license number that you will use to see patients and registry. Then the other thing is we have a lot of fake drugs in the country through whichever routes that they come in. Unfortunately, there is no one who does track and trace. We are not able to know this medicine, where did it come from which country, who is the manufacturer, who is the guy who imported it in, who is the distributor, which facility has it gone to, which patient has been prescribed for. Thirdly, there is a lot of misuse of antibiotics. Patients are just walking into a pharmacy with no prescription, asking for certain drugs, and they are given. So misuse of antibiotics, misuse of codeine and such controlled drugs, because there's no one who is looking at the prescription, because everything is manual. And that's the reason why we said that is impossible for to run UHC on that kind of paper-based system. So that's the essence of the digital health in terms of what the gaps it's trying to address. I think, was it some time back, I saw a study that came out. It said out of the 17 syntocinon drugs that they have sampled, for those who are not medics, syntocinon is the medicine that we use to stop mothers from bleeding when they deliver, so that they don't get postpartum hemorrhage. They don't get bleeding after they have delivered. They said only 6 had active ingredients. 11 were useless in terms of the content, in terms of the input, the ingredients. There was no active substance. So that tells you a lot the problems that we are facing, because there is so much fake. And then because you have picked that sample from the market, you are not able to trace back to where it came from, because you will find whatever number that is on the vial, because you don't know originally where it came from. When you go back to the manufacturer and say this is your drug, they will tell you no, 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 this is not our batch. We don't know where it came from. So because you don't have any evidence contrary to it, you are just stuck. So for that reason, we have the track and trace as part of the digitization. Finally, we have the big elephant, the Social Health Insurance Act. So the Social Health Insurance Act is meant to change and replace NHIF. I see a lot of people saying reform, but when you look at the dictionary, the meaning of reform, it's exactly what we have done. You change the structure, the process of something. That's how you reform. NHIF Act has been amended, I think, almost 4 times since it started. And we have done a lot of changes to it, to the point that now amending it further will not make any sense. Plus, the new Social Health Insurance Act is meant for everybody, while NHIF was meant for members. So the difference is there are benefits that you can get from NHIF only if you are registered, paid up member. While for SHA, we have introduced 3 funds. So the first fund is Primary Healthcare Fund. The second fund is SHIF, which now is comparable to the NHIF, because that one you need to be registered and contributor for you to benefit. So those two are equal, SHIF and NHIF. But remember, under SHA, you have primary healthcare fund, and then finally you have emergency chronic critical illness fund. So primary and emergency chronic critical illness fund are two funds that are appropriated by Parliament, and the money comes from Treasury. So it's taxpayers' money. So this is one area that you can lobby and push your member of parliament to allocate resources, because you benefit it just by being a Kenyan without even contributing. For NHIF, that was not possible under NHIF. So what else have we done that makes it different, that people are wondering, why have we not reformed and not? So the other thing that we have done is we have created a board membership that incorporates everyone. For the first time, we have the Director General sitting at the board of SHA. In NHIF, he was not there. He was not part of the NHIF board. For the first time, we have informal sector representative. So they have a seat. Previously, it was occupied, that seat was left for the Federation of Kenya Employers. But we said the majority of the contributors will be the hustlers. They deserve a seat rather than FKE. So that seat is given to Boda Boda Association, Stroke Juakali, and Matatu. So it will be sort of rotating amongst those three major associations. Then the other thing that we have made a change is who represents the counties. So previously it was the secretariat for 2 seats. Now we changed. We said one is the secretariat, but the other one is the other one we will leave it to the CECs, because they are the ones in charge of health, and they are the ones who understand the problems that they face. So they should be seated on the table. Then the other thing that we said is the providers, private and mission, also need a seat. Then Kenya Medical Association to represent the healthcare professionals to have a seat. That is the governance in terms of, and then the workers, of course, the unions represented by court. So after that, what now the next thing that we have done is to say, what else was the challenge? So the second challenge was NHIF used to operate on paper-based. So we said the process for SHA needs to be digitized from end to end. Then what was the other problem? NHIF used to have an open check in terms of how much can they use for administration. Administration means they can buy cars, salaries, travel, per diem, buy computers, paper, do road shows, all those things, allowances. So they had an open check. So what used to happen is at one point it was 80%. They will consume 80%. It came down to 50. It came down to 30. The latest was 15%. So 15% of everything that they collect was used for administration. But for SHA, we said that's too much. Industry practice at best is usually 5%. Why should a government body not conform with industry practice, which is the best practice that's well known? So we said for that reason, let's put that thing in the law so that it's not dependent on the goodness and the willingness of the board and management. So it's in the act. Administrative costs cannot go beyond 5%. Maximum 5%. It can be lower, but it can't go beyond 5%. Then we asked ourselves, what was the other issue? So if you're a healthcare provider, you know, if you wanted to be onboarded by NHIF, you needed a lot of talking to branch, to I don't know who, wait for the board to gazette you, and that used to take almost a year or two. If you are a provider, you know, a year or two, and that is the empaneling. But what has SHA done? SHA has said no, empaneling should be done by the regulator who licenses facilities. They are the ones who know whether my facility is licensed or not. So they give us the list. Once they license you and they give us the list, we empanel you within 30 days. We don't wait for, by law, within 30 days, we empanel you. Secondly, for this one, we have even removed the empaneling within 30 days. We are doing it now real time because we have connected to their system, which is their registry. So if you are empaneled today, if you are licensed today by the KMPDC, tomorrow you appear on our list automatically because we are connected to them directly. Then the second thing which has delayed is the e-contracting. So as a facility now, you can proceed and say, you can find yourself, you have been licensed, you move to the e-contracting portal, you start contracting. You apply and say, I am ready to offer the services, and you fill in your details and you sign the contract and you send it back. So how are we able to do that part? Because the reason why we were able to do that is the prices, which is the benefits and the tariffs, is something that we have also gazetted. So those two benefits and tariffs undergo public participation. Providers, professionals, patients, that is the process it undergoes. When we are finally done, it's gazetted. So if you Google today benefits and tariffs for SHA, you will find in the Gazette notice, and you will see what benefit you are entitled to and what tariff you are entitled to. So that makes it easier to contract the facility because the facility can already see these are the prices and these are the benefits. And for me, these are the services that I have. I can provide services based on this. But more importantly, because we know those benefit and tariff is a live document, it's a document that needs to undergo changes because things change every now and then. The disease burden change, the money that you collect changes, the incidences change, the cost of doing business change. So you need to update regularly. So for that reason, in the regulations, if you look at it, we have created a committee of around, I think, 11, 12 people. It has representative from SHA. It has representative from the Ministry of Health. It's based at a university for purposes of doing that research and coming up with the proper costing. It has a representative of patients. It has a representative of providers. It has experts from actuarialists, health economists, and the epidemiologists. So that committee can be petitioned by an individual, by an association, by providers, and say, we think the price of this is too low. Or you can go and say, you have forgotten to cover this disease. We need you to add this disease to the list of benefits. We think the prices of per family is too low. Please increase. So they will look at the data, they will look at the information, and if you do for them the data and the analysis and the burden, even better, because you will go with evidence. It's not just a request, But more importantly now, you can also petition your parliamentarians, MPs, to say, because chronic conditions X, we want you to allocate more money from the budget during the appropriation. So that also now makes it transparent. NHIF never had these things. All the things that I've mentioned so far were non-existent. The benefits and the tariffs, no one knew. It's only the provider who knew. The patients never knew. The how to amend and how to change, it was just NHIF on its own. Who was participating, they were doing it themselves, and then they were coming and telling us this is what we have decided. So that also is something that we have put in place. Finally, we said because all these things there will be always challenges in terms of dispute between providers and SHA, between patients and providers, between patient and SHA. We put a dispute resolution mechanism. So we have created a tribunal which is outside SHA and appointed by the Judicial Service Commission, 4 people and a chair. Their work is to make sure they receive complaints and they are able to sort out and resolve. Previously, that was done internally at NHIF. So NHIF previously was doing the premium. They were deciding how much you will pay. Secondly, they were deciding what is the benefit, what is the tariff. They were deciding which provider is is on the panel and who is contracted for what rates. Because providers had different prices. Anyone who was in the industry knows some providers were paid higher, others were paid lower. Then finally, they were the ones who are deciding if there's a dispute, that they were the ones who are resolving. So if you look at now the act, you will realize that is very much different. And you needed to be a member of NHIF and a contributor for you to benefit. And if you are contributing today, if you are in the informal sector, you are supposed to wait for 60 days before you are getting benefits. For SHA, so for SHA, in terms of patient benefiting, for primary health care, all you need is just to register. That's it. You don't need to pay anything to benefit because that's tax funded. It's not our money. For SHIF, which is for now the services you will access in level 4, 5, 6, and the primary healthcare is accessed in level 2, 3. You will have contributed 2.75% of your income. And once you contribute, you benefit immediately. There's no waiting period. You are sick, you happen to be ready today, you just pay and you move on. Not that I'm advocating you only pay when you are sick, but there's no waiting period. Finally, emergency care, emergency chronic critical illness fund. Emergency, you don't need to be a contributor, neither do you need to be a member. You just benefit because you are involved in an accident or you have an emergency. This one is being implemented now for the first time. Emergency as a right is in the Constitution. It has been in the Constitution from 2010. 14 years down the line, it has never been implemented. It was also in the 2017 Health Act. It has never been implemented. This is now the first time we are daring to say we need to give dignity to our people and we need to implement this right. And how are we doing? It's tax funded. So we will not ask you to have registered and to be a paid up member for you to benefit that. So now, I think the listeners now have understood that when they say reform, they can clearly see this reform is not only at SHA level, but it's a reform even for the public health facilities through the FIF, the community health. At the SHA level, through the the primary healthcare fund and the emergency, which now gives access to the poor because they are the ones who are most affected by these problems. Then let me come to the transition, because if I don't speak to it, I will be disingenuous. Has there been a problem? Definitely yes. Could we have done better? Definitely yes. Are there patients who have been affected? Definitely yes. But have we tried to solve all those issues? Yes. One step at a time, we have been able to address most of the issues. Most of the challenges that we have faced are now behind us. We have managed to settle a few of the pending problems. Uh, and hopefully, by the end of next weekend, most of the issues that we have faced would be over. So, what we will be discussing is how do we now get as many people to pay up as possible? Because the fund becomes only sustainable if many people contribute. It's the issue of the purchasing power. So if we have enough resources, then we are able to say now we can pay providers promptly because we have money. Oh, I forgot one more thing. NHIF was allowed to invest. Under SHA, we have removed that. We said the business of SHA is not to do business. The business of SHA is to pay and finance providers, healthcare providers, public-private mission. So we will never hear SHA again has bought 10 acres of land, which has a dispute in Karen. They have built, SHA has built a parking lot that has been in the Parliamentary Account Committee for, I don't know, PIC and PAC for the last 20, 30 years. We will not, because that's not our business. We have 5% for administration and 95% to pay providers. Uh, I think that concludes my just not so brief introduction, which I wanted people to understand first where is all this coming from before we now delve into answering specific questions. Thank you very much, Doc.
Yeah, thanks, Doc. That was exhaustive. One thing I'm getting a lot of inbox is this is not a political space. We have not been paid to sanitize anything. I think I actually held this space because I'm a key stakeholder player in healthcare. I'm a doctor. I treat people. I have a clinic. I see patients. Like right now, the occupancy where I work, we have a occupancy of 100 bed capacity, and for the last 2 weeks, we have had 4 patients in all. No maternity. The whole hospital has 4 patients. Yet it has a capacity of 100. Normally we are 50, 60%. That is the case. If I look at the chart on the space, there's someone who says the facility has decided to lay off some of these people because of this chart issue. So the reason why I held this space is number one, to get that kind of clarity from the chairman of SHA. Number two is for us to also raise our concerns or our issues, give our experiences. When you say you reject SHA or SHIF, tell us why you think so, or if you have any recommendation. So it's, for me, it's very objective, and we're hoping will be very, very respectful. Of course, this SHIF and SHA has been enjoined in politics, reject, Ruto must go, and those kind of things. So today I'm just being very objective as a player in the healthcare space. So for the speakers, they are doctors, health, normal, citizens, people who consume healthcare. I believe everyone consumes healthcare. So if you want to speak, also raise your hand. I'll start with my cost. I think I'll ask my questions later, but I want it just to be an open forum. If you have comments, if you have questions, if you have, Chairman has said a lot about it. So Nigel, I don't know if you have anything. I saw Elvis' hand was up, and then citizens, and then that orderly. And then when you're speaking, let's keep it 3 minutes maximum. We want to end it by latest 10. Again, today is also Friday for some of some of us. So yeah, co-host, do you have anything else before we, or
I
any
think
question or any comment?
I think we can start then. I think I'll join in later, like after around 15 minutes, so like they can
Yeah.
just proceed.
Okay, Elvis, and then citizens, and then now in that order.
Hi everyone. I hope
Yeah,
you
Elvis, yeah,
can
we can
hear
hear
me
you.
clearly. Oh, okay. So my question to Dr. Abdi, I think I have two questions, and the first one is, what was the reason to move from NHIF to SHIF or SHA? Because if NHIF had issues, why couldn't they just fix NHIF rather than wasting taxpayers' money to move from NHIF itself to SHA or SHIF? Then the second question, we were getting texts about our details being moved from NHIF to SHIF. We didn't have any sort of consent. Our information was used, our data was used. Potentially, that is data breach. And, some of us are very sensitive to our details being used without being consulted and stuff like that. That was not considered as well. And then the other thing was about the cost cost of preparing the system, the SHIF or SHA system, which was estimated to be about 104 billion. Is what kind of system is that, and is it a priority? Because if we look at our country, many people can't access healthcare, and 104 billion is a lot of money that can do a lot of things than coming up with something purportedly to be a system, which to me it doesn't really make sense spending 104 billion shillings. Those are the questions I had. Meanwhile, nitaendelea kusikiza, and if I have anything, I'll question.
Doc, can I answer as quickly as possible so that we
Yeah,
keep on
yeah.
moving?
You can just
Okay.
answer as you go. Yeah.
Okay, thank you. So why move? I have explained, and I will repeat it again. NHIF was for members only. SHA is for every Kenyan. It's UHC. It has two funds where you don't need to contribute. For NHIF, you needed to contribute and be a member. So it was a private members club. If you did not contribute, there was no benefit for you. If you
But
do not
Doc, my question,
register, I'm just showing you the difference so that you see. And I have told you the act has been amended many times. So
but
there was no way you could fit in the same act and introduce those two other funds.
my question still stands. I feel like I haven't been answered. Was there? Why couldn't they just implement this thing within NHIF itself rather than moving the whole thing, like taking all that process to move it? Yet we can renovate, we can reinvent, we can do all sorts
It
of repairs within NHIF.
it has been done and it's not working. Do you know the act was amended in 2021 stroke 2022?
Yes, I'm
Are you
aware of
aware
that.
are you aware?
Yes, I am aware of that.
And where did it go?
It
It
didn't
never
go.
worked.
Yes,
It,
and
it,
now
it, it,
and now the
wait.
question is, yes, it never worked. How sure are
Yes.
you that SHIF is going to work or SHA is going to work,
Uh,
regardless
uh,
of it being UHC or like you
uh,
taking care of
oh,
everyone? How sure are you that it's going to work? Because the
you
same people who
then
implemented or who
you
amended the act, they are the same people who are going to be within the SHA or SHIF. So how?
you
Yeah.
wait and watch and see. So that you know whether it will work or not. Let's come back December and we have this discussion. Did it work or did it not work? What a December? November. November is not very far. It's 2, 3 weeks away. Let's come and talk November 1st. Somewhere, Doc, you can organize this space and we have that discussion. Let me continue answering the other questions so that we don't do back and forth unnecessarily. So the issue of movement of data, there was a legal notice. If you had seen, and if you have not seen, there is one. which was shared that the data, because the NHIF Act repealed it and it was becoming obsolete. There were people
Now,
who paid. Wait, let me finish. Allow me to finish. Uh, the beauty is if you feel there was breach of data, you can take your case to the Data Protection Act Commissioner, and or take it to court because we followed all the necessary laws and all the necessary data laws that provide this. So there was a legal notice for it in terms of movement. There were patients who were benefiting, who also needed their data to be moved to the new system. And for that reason, there was no way we could have allowed them to remain where they were. Number three, the other question that you have asked was the issue of the system. If you are listening a little bit earlier, you would have realized that number one, the system is not for SHA. The system is digitalization of the whole healthcare system. And it's not for one entity. KEMSA is in it, regulators are part of it. All public health facilities, county and national, are part of it in terms of both hardware and software. And finally, the amount of money is not for 1 year; it's for 10 years. 2 years of setting up, 10 years of this work. So the 104 billion is not for 1 year; it's for 10 years. Finally, uh, I think there's even the PS talked about this. Government has not paid a shilling for this 104 billion. Thank you. I can take another set of questions.
let me just rebuttal back a little bit on the second question. The second question, you've said that there was a gazette notice to inform the public that they will be transferring our data from NHIF to SHIF. But now you see, one thing all of you need to understand is that with things to do with data, I can either say yes or no, and nobody asked me to either to say yes or no. So to me, I feel that any data that was moved from NHIF to SHIF was breached for literally everyone, because giving a gazette notice or a notice that you're going to move this data from point A to B without consulting anyone by asking them either to agree or not, that is not how it's supposed to be done. And in my opinion, I think that is a big data breach. And even if you read the GDPRS policies globally, for them to touch any data or come up with a new system and they have to move your information from point A to B, they have to ask you, they send you a text to either you say yes or no. If you say no, they will inquire, they'll try to find out why did you say no. So it can't be just that you come up with a notice and say from date A, we'll be moving your information from point A to B, and you have to comply. That is not how it works. So that one I don't agree.
Thank you. I think we will just allow that the lawyers and whoever to handle it. Thank you very much.
Yeah,
Yeah,
okay.
okay.
I
I
think
think
I'm seeing quite a
quite a
number of
number of
speakers.
speakers.
This
This
guy,
guy,
Nani,
Nani,
Gilbert, and
Gilbert, and
then
then
Darwin.
Darwin.
I'm
I'm
seeing
seeing
other
other
speakers.
speakers.
Theory
Theory
push.
push. Gilbert,
Have
have
a
a
go.
go.
3 minutes.
Minutes.
If you
If
have
you
a
have a
question, a
question or
contribution.
contribution. Thank you, Daktari. My name is Gilbert, and I work in Westpokot. I'd like to tell Daktari one thing. In as much as we are marketing this SHIF SHA, let us try as much as possible to be honest to the citizens of this country. When you come and tell us that primary healthcare will be free, it has always been free. There's no one who has been asked to pay for health in our dispensaries and health centers. The only thing that SHIF is coming to add is that we must now register before we
we go to those dispensaries and health centers, which I think is a disadvantage to majority of Kenyans. Number two, on the issue of dialysis, President Kenyatta did a fantastic job in making sure that many hospitals in the counties have dialysis centers. And I've been seeing Daktari here and the CS saying that the 10,000 shillings that Kenyans that they shall be paying will cover for erythropoietin and iron sucrose. That will never be enough. 10,000 alone is not enough for consumable for these dialysis in these hospitals. And for maternity services, they've also said that it shall be free in our primary healthcare centers, but in level 4 and 5, I don't know how they'll cater for it. So as we speak, hospitals in West Pokot, they are charging mothers to deliver in level 4 and level 4s, which to me I feel like it's taking us back. In the past, NGOs such as AMREF has played a big role in making sure that these mothers are delivering in the hospitals, and I feel like these people are taking us back, which we expect to see the data for mothers delivering in our hospitals really drop if this will continue. And finally, Dr. has said that we should wait and see to see that SHIF will work. So when he says wait and see, what does he mean? That Kenyans should suffer more? That Kenyans should die? Like the way that there was that story that we saw in Eldoret. Should we suffer more for them to agree that this thing is not working for all of us? I took my kid to the hospital and I was charged. I used to get comprehensive cover under NHIF, but right now I'm not getting anything at all. Thank you.
Thank you. Let me answer. It's good. You talked about comprehensive. And I understand where you are coming from, because people who used to get comprehensive medical cover were the people who work for us, people who are in government, the three arms of government, including national and county government. And that was not sustainable. Actually, that's one of the other main reasons why we had to change and make uniform in terms of contribution and in terms of benefits. There are no more equal members than others. We are all equal and we should get the same benefits. Secondly, primary health care is available in public, private mission. It's not in public facilities only. So the capitation is to all the three different ownerships. And if you look at the finance acts of each of the counties, they publish, these are public documents. All you need is to look at what are the charges for hospital fees. And you will see it with your own eyes, how much it costs to do registration, delivery, and all other services that they offer. That is the finance bills of the counties for you to check. Thirdly, dialysis. What has happened is we have moved it from 9,600 to 10,650. I understand when he says that it's not enough. The biggest challenge we have had in this country is we have a lot of brokers in between the manufacturer to the final distributor to the facilities. So Even if today we say dialysis will pay 20,000, I assure you the supplier will increase his supplies to 18,000 or 19,000. So the facility will be crying, saying, it's not enough. It will never be enough. So we need to find a way of addressing how do we do direct procurement from manufacturers or bulk procurement collectively from one distributor rather than having 1,001 distributors disadvantaging. And there are many providers who are able to provide erythropoietin and iron sucrose. This one, I am not talking about from theory. I have done it as a provider when we were being paid 9,600. So it's not hearsay, and it's not I have been in that position and done it. For maternity, yes, you will. We will pay for both level 4s, select level 4s, and level 2 and 3, and we will pay 10,000 for normal delivery, and we will pay 30,000 for cesarean section. That's what is in the tariff. Previously, these amounts used to be 2,500 and 5,000. So public facilities now have an advantage. For the first time, we will pay public-private mission the same rate. NHIF used to pay lower amount to public facilities and higher amount to private facilities. They used to pay 2,500 and 5,000. And they used to pay private facilities 5,000 and 17,500 for cesarean. 5,000 for normal, 17,500. Those are facts. Unless you can bring different facts, I am willing to challenge anyone to show different amounts than this, and to show where public and private were paid the same amount. It's the first time, and it's a public document. Go and Google benefits and tariffs. You will see it doesn't differentiate the ownership of the facility. Prices are the same. Thank you.
Yeah, hold on, Kiasi too, Nani.
Hold on,
I'll give you
Kiasi
a
too,
chance
Nani. I'll
to
give you a
rebut
chance
if you have
to rebut
a
if you
follow-up
have a
response to
follow-up
what
response
Doka
to
said. I
what
want to
Doka
ask
said. I want to ask
Dawin and then
Dawin and
Mohammed
then
and then Kush. I
Mohammed
want
and then
also other
Kush. I
speakers
want also other
to
speakers
speak, and then
to
you'll come
speak, and
back.
then you'll come
I'll
back.
give you a chance to
I'll give you a chance to
Gilbert. I'll give you a chance
Gilbert. I'll give
to
you a chance
comment back.
to comment back.
Dawin and
Dawin
then
and
Mohammed and then
then
Kush.
Mohammed and then Kush.
So, Dr. Mbiti, thank you very much. I don't know if I'm audible and clear.
Yeah, go ahead.
Thank you. Dr. Abdi, thank you. I've been listening. And first of all, let me just declare my stand. I have never supported this SHIF thing because of some very many reasons. In as much as I've tried to flip it and look at the good side of it, it's still not appealing. So let me start here. Because I work in the hospital, I wake up to go to the hospital to deal with patients, go back, and that is my day-to-day routine. And the fact of the matter is there is suffering. The suffering that is going on in the spaces of hospitals is so despicable. You know, there is nothing, there is no media that can report the amount of tears which are not focused on camera. Friends and Dr. Abdi, there is so much suffering. I work in the surgical unit. I have cancelled lists because of NHIF and SHA thing. The program, the thing of SHA, it's just not working. And you see, I don't know, when I listen to you speak, I hear very good English verbs and very good promissory talks, which are are very sounding to the ear. But you see, where I work and the spaces I feed on, to the colleagues who are in these spaces, people working in private facilities, there is suffering that even if SHA starts working now, SHA will never pay the losses and the pains that citizens have inflicted themselves because of this untermed and unsaid delays. So, one, you rolled out a system which was not pre-tested, and now the rolling out of the system came with a lot of political language also to SHIF, because SHIF is coming to take a lot of my money. It's coming to give me services that are not equated to the money, and it's going to be privatized and run by some individual. So there is no political acceptance of this SHIF. Two, there's someone who's advising the CS and the Ministry of Health where you sit, and they're not telling you the truth. So my brother Abdi, the chair, the suffering that the people are going through hapa kwa ground, bana hata SHA ianze kufanya kesho, you may not compensate the losses. Some people, when you speak about dialysis and missing a session, it may look very easy, but it is very difficult because these people depend solely on those dialyzing machines. I've heard you say wait and see. We can't wait anymore. We can't see anything right now. Whatever is in my scope of vision is the SHIF versus NHIF. NHIF looked. It may have been a bad insurance to the government's eyes, but as of now, in what we are seeing, NHIF was a darling. SHIF has come with a serious turbulence that is also costing lives, especially in patients who really depend on healthcare on a day-to-day. But number two, I heard you speak about something on digitalization. And there is a lot of hope in when you're talking about we are going to digitalize healthcare through insurance, which I listen to it because we are going to the spaces of digitalization. But my brother, remember there was digitalization before. Do you remember the NTSA digitalization of driving licenses and 15 point something billion shillings was lost? Do you remember the digitalization of e-citizen and we lost a lot of billions? After testing such kinds of losses in the word called digitalization, what makes us confident that this is just another what makes us feel like this is not another yet form of digitalization, which is coming to take away, which is creating a planned loot, a planned corruption? Then number three, my brother Abdi, the monies you're going to cut us versus the services you're going to offer, bana, they cannot balance. Hata hiyo niambie kwa lugha gani, you cannot say you're deducting me 2.75%, and we only have 3 million civil servants in this country, and then 54 million citizens, and you're telling me that 3 million almost 3 million civil servants will shelter and carry the weight of the entire country. It can never happen. Obamacare, you remember the Obamacare? Obamacare came with such a module. It collapsed at birth because you cannot carry the indigence which you've been speaking about for the political mileage of it so that it can receive an embrace, that 20% can be deducted monies in their pay slips for the 70%. But look here also, Dr. What also is coming out as a bad show is the 70% who are not in the formal setting, the informal setup. You've come up with ways you're going to assess them, which I don't agree with. You see, in this country, I can own a TV which is worth 55,000, but that is not the value. That's not the valuing system of how I am really. So the valuing system of the informal sector really is too skewed. So kwa hii mambo tu tuambiane ukweli. One, we started this program too early without pretesting it, without looking at the implication. I'm just winding up. I'm finishing. Two, it has received a huge backlash from the public. Why? It has come with the test of Huduma number. In as much as we can want to love this thing, but the how it has been choreographed, it has come with a lot of turbulence when it comes to healthcare provision. We have operated in a system which has never worked. 2 days ago, we were saying, mlikuwa mnatuambia we have reverted into manual. People are running around with papers. Today, SHIF is still not working. I have to cancel my theater list and tell patients, but maybe try next week. But when I listen to the government and I read the memos, the things are moving on swiftly. SHIF is working nicely. The rollout phase is okay. Bana tuko nchi gani? Where is the difference? Why am I seeing different people suffering? Yet when I come to news na ama kwa your pressers naona unasema things are okay, bana, things are not okay. So for the sake of the patients, especially, let us kwanza, Abdi, I want you to apologize and revert your neno ya wait and see. We cannot wait and see. And tell us the fact on how this thing is going to roll out and actually starting helping people. Asante sana.
Thank you, Dr. Darwin. It's good you started your first statement by saying it's politicized. And you are the one who has said a lot of things which just sound political. No facts, nothing. All the things that you have said, I tried to get a question out of it, and I couldn't find anything. And I will just show you that you just politicize. It's like you are in a rally trying to give a speech. Number one, there are no 3 million civil servants. Just go and get your facts properly to begin with. There are no 3 million civil servants in this country. Two, 3 million civil servants are not the only people who are employed formally. That is also a fact that you need to realize. Everyone does not work for government. There are people who work for companies in the formal sector, and they are on a salary. Three, not everyone who works in the formal sector will have an increase in their rate. That's also a fact. You don't need to trust me. You just need to go Google NHIF rate, then do a similar 2.75 for the same salaries. I will give you a simple one. You go and check right now, Google. The person who earns 30,000 currently pays 900 shilling. If you do 2.75%, it's 825 shilling. That's a fact. Do you know how many such people exist in the formal sector? You don't have the data, but I will now educate you. 60% of Kenyans who earn a salary earn below 30,000. So meaning 60% of the contributors will actually have a reduction in their premium. The few privileged ones, like you, a doctor who works in the public sector, are the ones who will benefit, who earn a lot, are the ones who will pay something extra. But more importantly, people like you are the ones who will benefit more.
Is there audio? I lost audio.
Because, can you hear me?
We can hear you, Doctor.
Yes.
Okay. So people like you are the ones who will benefit more because you are the ones who will do a case in the public sector.
Is anyone
go
presenting?
to the private sector.
Yeah, there's a... Dr. Abdi, you can continue.
Okay. You are the same guy who now maybe has cancelled his cases in the private sector because that's where you are going. And it's the same patients who are in the public sector that have moved to the private sector because they have a cover. And the ones who can't afford are the ones who will remain in the public sector. If I look at again that civil servant scheme was the biggest loss-making scheme in the NHIF. Civil servants were consuming 1.5 times what they were contributing. And where was the halftime? Because they were paying 6 billion and consuming 9 billion. Where is the 3 billion coming from? The 3 billion were money paid by Wanjiku, you and me, and money paid by the other formal sector. But who was getting extra benefits than the rest? It was civil servants. They had dental of 50,000, they had ophthalmology of 50,000, and they could get anything that they wanted, including flying out of the country for treatment. And where were they accessing these services? From the private sector, because they don't trust the same public sector that they work for. So, Darwin, don't politicize this thing. Put the facts on the table. Just say, I was the beneficiary and it was working for me. Let the rest of Kenyans stay where they are, remain with the small benefit that they had. Thank you.
Mbiti, I beg to
That, Darwin,
I
just
think
a
that
moment. Darwin, just a moment. So, Dr. Abdi, I think you mentioned something about the 60% below 30,000. Are you sure about that?
Yes, because you see, we have the data.
It's
60%
not.
of the current contributors to NHIF from the formal sector will have a reduction, and I can share that poster. By the way, I will
It's all
send
right.
with I will send Dr. Mbiti to his WhatsApp so that he just compares and sees the reduction for those guys who are the majority. And
So it's
then
all right.
let me add one more thing.
Mhm.
Another 30% will have a minimal increment. And that minimal increment is 1,000 shilling because another 30% earn around 100,000, up to 100,000. But you have 5% who earn more than 100,000 that will have a higher increment for sure. And this is the other thing that I want to explain so that people understand. The system we had for NHIF, it was regressive. It was punishing you for being poor. Because what was happening is if you make 5,000 and you pay 500 shilling, you are paying 10% of your salary, of your income. But a guy who earns 1,000,000 was paying 1,700 maximum, which is 0.017%. Surely, if you are progressive, the same way you have the payee, guys who earn lower should actually pay zero. Then as you move upwards, it should be 5%, 10%, 15, 20, 30, 35. That is progressive taxation. But for us, we said we don't want to go that route of progressive and we don't want to remain with regressive. We move to proportionate. Pay as per your ability a portion of your income. And that's how we have the 2.75%. Thank
That's
you.
all right. So, I've shared an article, I think, which was done by The Nation, I think, in 2021 or 2022, which
Yes.
showed that 58% of Kenyans actually earn above 50,000. So, now, this is a question seems like what you're telling us was based on 60% of the formally employed earning below 30,000. So it's a bit shaky, but I think we can move on to the next question from another person.
I told you 60% of the contributors will have a lower contribution compared to what they were paying when they were paying to NHIF.
But
60%.
how sure are you about that when you don't have data on those who are the self-contributors?
No. I'm talking about formal, not informal.
So
Formal
from
contributors.
from
Because you
what
see, informal were just paying a fixed amount of 500 shilling.
so from what
There was no change. They were not paying more than 500 and less than 500. Whether
so
you are earning 5,000 or you are earning 1,000,000 or 10 million, you are only paying 500 shilling.
because by my estimation, if you're earning like 40,000,
Yes.
I'd expect that will probably be an increase to 1,100.
Yes.
Yeah, so I'm thinking something probably from 40,000. That's why we'd see an increase 50,000. So I think
Yes. Up to
so.
100,000, they will have a minimal increase of 1,000 shilling, because 100,000 you are paying 1,700 currently. But with the 2.75, you will pay 2,750. So it means if you deduct that, you will pay 1,050 shilling more.
So actually, it means for most Kenyans who are formally employed, they'll be paying higher contributions since at least 60% earn more than 40,000. But I think we can move on to the next one.
Check your data.
Yeah.
Check your data. I have the data. I can share the data with you.
I've shared the link. on the chat. You can check. You can check it, then you can post yours. Okay. We'll move on to the next. Who else? It was citizens.
But now being on the forefront, it's a bigger picture.
Thanks, Doc.
So you can go to Odoro Tieno. Please keep it to 3 minutes. Actually, let's just do 2.
Okay. Thank you, Dr. Mbiti. And my question to Daktari here, if you look at the way we are approaching, let's say, the spirit of health for all, and there is a term that we use the indigents, and we've been repeatedly told that those who are not able to pay, the government will come in to support them. But now the approach in implementing this is fairly skewed. And if you look at it's what I would term negative selectivism, hereby when we talk about means testing, and by practice across board, whenever you apply selective negative selectivism, as we are doing it with the means testing approach, the outcomes are usually very negative and skewed. For example, here we are going to end up with misrepresentations, misclassifications, and here we are going to also end up with stigmatizations, and we'll also end up with a situation whereby those who are supposed to be beneficiaries are increasingly shying away from stepping into the limelight and receiving these services as we speak to them. Because, for example, we've seen what this means testing has done, for example, with the education, the funding model for higher education. You realize that we've got students coming up saying, oh, we've been misclassified simply because the mechanisms and the tools that we are applying to means test are flawed. And you realize that this alone, I don't know, maybe Dr. will say how much goes into the means testing exercise in terms of administrative cost, which is also fairly a huge amount, a huge chunk of it. So I would ask Dr. why would they not basically use the approach, for example, the approach that was used in bringing on board HIV care treatment services? You know, the care and treatment services, yes, the funding was pulled together from various development partners and the rest, but everyone, each and every household, the government didn't do a means testing to find out who can pay and who cannot pay. Everyone within that pool and was realized to be affected or infected with HIV was eligible for the service. So can we also find, let's say, a positive selectivism approach mechanism that can bring all the indigents within the fold without going through the approaches of means testing, which we also end up with one classism, in that at the end of it all, you are basically placing a tag on every, or on each and every, let's say each and every indigent person in this country, which does not also augur well with the philosophy of health for all, whereby everyone else can step into the health facility without shame to receive care at any particular time within across the country. That's my question. I submit.
Thank you. Before Doc, you go in, I think also, so that we save time, I would like you just note, because I realize when one person asks and the response will take a lot of time. So I would have us like 3 people speak, and then you note, then you can respond to it at once, kindly. I want to bring Dr. Theory. He has been up, and then we'll bring Kroba, at least from a doctor, and then Kroba, as seen, he has been having some videos, some short skits on this SHA thing. So I'd like also to hear from him. And then for gender balance, I'll bring Monica. And then I think after those 3, Chair, you can now respond. Then we bring the next group. I'm seeing Dr. Boss, I'm seeing Dr. Onyimbo. So I'll bring you guys on board. So let's have Dr. Theory can give us his perspective. He's quite experienced in this sector. And then Kroba, then Monica, and then Chair, you can respond if there will be questions to you, so that at least you also save time. We have like 30 minutes maximum to go. Theory, karibu.
Asante sana. Good evening, everyone. I'm Jambo. My name is Theuri. I come from Kenya Healthcare Federation. We are the largest business member organization in the sector. We oversee the entire ecosystem in the non-state actor space across the entire value chain. I'll take about 4 minutes, so I'll try be concise. First of all, Abdi has kept me awake this entire week. But we will score that out later once the rollout is over. The country right now, we have 56% of the care being given by non-state actors, with 8% of that being from the faith-based organizations. So what you call the private sector, the strict private sector, is about 46%. We have about 100,000 to 75 beds in the country. So you can do the math of that. The other thing is most of the businesses in health are small, medium and micro enterprises, meaning that they cannot sustain prolonged credit periods. And most of our businesses, on the other hand, are largely owned by women and youth. This is data you can pick from the Economic Survey of 2024. That means that health is largely an OPEX business, and the life of any OPEX business is cash flow. Pursuant to that, it is not only in the private sector, but also in on the government side. Most governors will indeed tell you that they're having a problem with an increasing recurrent expenditure without much to invest back. So a couple of landmark laws were passed, just like Abdi said, and this, in my interpretation of it, was towards policy stability. We have done that, but on the other hand, we keep on taking with the finance bill, quite an unstable tax regime we have in the country. That said, it goes to the next question: will the rollout of a social health be the elixir to what we are facing? My answer is SHA is not UHC. UHC encompasses many more other things than just the healthcare financing component of it. And ideally, if we were to get this right to the T, and we don't sort out the other legs on which UHC stands on, we'll end up with care that is affordable but unavailable. And Dr. Abdi has mentioned on commodity security, which is something that is really close to my heart. If we do not sort that out, we will end up in a bigger hole than we have come out of. What is currently working for SHA are a few things. Some of them may be repeated because Abdi has mentioned them. One is the restricted expenditure by the authority, which is at 5%. I think that is a good thing from where I stand as a representative of providers. The other thing is SHA cannot even have an interest earning account, meaning that any monies they have, they must sweep them out to the provider space, both government and the private sector. The other thing is we were intimately involved in the benefits package in its design. We gave the costings. There are places where we feel some of them were indeed implemented. Others could use quite some improvement for the simple reason that the current benefits package is tied to a 2-year review cycle. And that is very tough for any business, especially in an economy as that is quite volatile like ours. The volatility comes especially in the forex space because it's a fixed fee for service. So what we are being paid is known, but the components that are going into this particular service are unknown. The cost of human resource, rent. I mean, forex is ever fluctuating, and those kind of components. Those ones remain very variable. And in such a space, then we don't want our providers to be innovative in how they are offering care. We want them to be focused on quality so that we do not change how the system is incentivized and in an attempt towards business continuity, people begin doing what I call interesting things. The fourth thing that I believe would be a plus is if we crack the digitalization of the claims management process. As it is right now, NHIF, of course, was judge, jury, and execution. There are various components of the Act now that have disaggregated those functions into various administrative units that Abdi mentioned. My appeal is that these are put up quite quickly. That is one, the benefits and tariffs package committee and the tribunal. Those need to be set up because that is what brings completeness to the Act. I have some questions that I think anyone who has read the Act should have. One, what are the weaknesses of a progressive model? Because there is no model that is immune to that is wholesome. So even the progressive model of collecting money has some weaknesses. Why wasn't perhaps a consumption tax considered? So maybe if 0.5% of VAT was called a UHC levy, and that crystallizes at every point VAT is chargeable, would that mean that someone who's earning the 1 million bob, of course, is a bigger is a bigger payer of VAT than the person who's maybe at 10,000? The second question is the proximity testing. Research on my end shows that there's a tendency towards sometimes overstating. What are the mitigating measures that we would have on this? That is a transition. What are the bigger plans around this transition? Today, I can confirm, and I'm being very dispassionate in how I'm looking at this. The system upgrades that have been done have indeed worked. And then we hope that the same will be pushed through to all providers so that access to care for the common Kenyan, and that is where my interest is largely at, would be improved. The pains of the transition must be reduced as best as we possibly can as a fraternity. My final point is to everyone listening to this. We must put our politicians to account. And the reason I say this is very simple. Health is the remaining public good that we have not sorted out as a country. And we must quarantine health from the vagaries of the cyclic nature of our politics. If Mbito is to become a governor today, then he will come and do his thing. The next time when he's out and it's Chibanzi's turn, then he will come with his own way of doing things. We must quarantine the sector from that. And what will sort that out is a blueprint for health. and we are sit down as a country, we have a broad-based government right now, the conversation must move towards what is it that we want as a country. And we decide how we are going to do this in phases, so that on this particular phase, we concentrate on one component as we are building on the rest, and like that. And we'll be able to judge our leaders on how much acreage of that blueprint are they able to cover when it comes to the next re-election period. Because much as politics allocates resources, it is our work in the sector to ensure that the sector is run as best as we possibly can. I think that would be it from me. To my friend Abdi, of course, I continue to wish you the best in the current endeavors of the transition. Thank you.
Thanks, Doc. I would like Abdi to, I think, just respond to some of those things that Theory has asked, and more importantly, also what Odore had asked. He talked about, I think, the what was it? Yeah,
Proxy means testing.
yes, testing. I also
And
had,
while
I also had that question around.
While at it, we usually have a sharp point of contradiction with Abdi, and that is dental. Dental services share modifiable risk factors with very many NCDs. Abdi, tupatie dental tafadhali. Abdi, tupatie dental.
Dental was available to the few chosen ones, and the chosen ones are the ones who are paid by our taxes as civil servants. It was not available to the
Give
rest.
everyone dental, sawa.
It was not available to the common man. You
Kama
and me
aesthetics. Common
were
wananchi anaweza kukosa meno lakini anaendelea tu.
Yes, wakina Darwin ndio walikuwa wanapata hizi dental benefits wakienda clinic ya Dr. Theory. Anyway, that is just a side show, but let me answer the other questions. So there is the issue of means testing and identification of indigents. This is one area that we have really abused in this country. When we talk about indigents, politicians are the ones who decide, and more so the professional administrations also pick and say Abdi is an indigent. There is no formula, there is nothing to show that this is a person who is an indigent. So you will find when you run that data, the chief has put his wife as an indigent. Surely, how can your wife be an indigent and you work for government? It loses the meaning of who is an indigent. So how are we doing it? We are not deploying money to collect that data, to identify indigents. The proximity testing is something that you do from your phone. You just go to your Afya Yangu portal, you register, you fill in, you answer questions, and you will be able to get, if you are an indigent or not, it will tell you. If you get a payment of 50 shilling and below as your premium, it means below 300 shilling, then it means you are an indigent and you need to be paid for. So there is nowhere you're embarrassing yourself to say, identifying yourself. You are doing from the comfort of your home. There's no one who is coming to tell you, you are an indigent. And that means you are automatically paid for. And when you go to a hospital, it just says you are eligible. It doesn't say you are an indigent. There's nowhere it's mentioned that you have been paid for. It says you are a paid up member and you benefit. So there is no money and there are no enumerators that we are sending to the field to go and identify indigents. So there is no cost. Two, that is data that we have trained and modeled, and that this is data that was done by the Kenya National Bureau of Statistics. The survey that they did for poverty is the one that we have used as the base. But we also did for 8 counties. We went and tested the data and modified to make sure that what it brings out, it rather underestimates than overestimates. And we did it at the household level and rural Kenya to just see how this data, whether it brings out the correct information. So that is the way we have identified, and the way we have trained that data to pick up indigents and to pick up the premiums for the informal sector. Then there is the question, committee setup. Yes, definitely, we will have that in the course of this quarter. We should be able to set up. One is out of our way because that is done by the Judicial Service Commission. We will, of course, urge the JSC to do the setup. That is the tribunal. But the Benefits and Tariffs Committee, we will push for its setup as quickly as possible before the end of this quarter. The issue of tax. There is one thing that we need to realize. We have two already funds that are tax-based. Now that comes from the consolidated fund. We don't need to also put another sales tax. Sales tax generally affect the poor more than they affect the rich people. They are very regressive. What happens is when you it doesn't apply equally. For example, if you put 50 cent or 1 shilling or 5 shilling on a loaf of bread, for example, just as an example, and today I have worked very hard and I have made 300 shilling. So if the loaf of bread was 50 shilling and you have added 5 shilling, you have reduced my 300 shilling by an extra 5 shilling. But me and you, who maybe today have made 10,000 shilling, when you reduce 5 shilling more from my 10,000, it's not, you don't feel it. But the guy who would have used that 5 shilling for something else. So it affects, it's very regressive, and it doesn't, it's not equalizes people. It just makes the poor more miserable by putting those kind of levies on certain things. That's the nature of having a specific tax on certain products. So, and that's called earmarking. We rather get from the consolidated fund for now. In the future, maybe you could go to for luxury goods and say luxury goods, we increase or we add a certain tax and make them, earmark them for health, but not on day-to-day things that the common man uses. I think I have touched on all the questions, if I'm not wrong.
For the proximity, let's say if BT decides to say is an indigent, and since you say there's no enumerators, nobody to confirm whether the information you're putting is actually correct. So how are you able now to correct, like with the actual now situation on the actual now real life situation, just to ensure that somebody is not lying on the form?
So the model and the data is trained to pick the lies. So the data is trained on lies. So anytime you lie, it also is aware that these two don't match. So your answer here and the answer here don't match. The answer here you have given and the answer you have given here don't match. So it means the data is actually trained. And for us to begin with, we rather under underestimate the premium for the informal, then overestimate it. Because our worry is if we overestimate for the common, the hustler, then it will be a challenge in them paying. But what the other thing that we are doing is if you say dispute what you have gotten and you say the premium is too high, then now we do the observation where now we send someone to check and confirm what you are disputing.
I think still this is still like now constructive criticism on it. There's no way you can actually verify whether the information someone has given is true or not. So we're still going to have the where you reported the chief's wife's problems. So I think it's something that you should consider, because even like KRA, they have to go to the ground. They have to come back. They have to come to your business and confirm that this is actually the revenue you're making or whatsoever. So you can't really say that the system will detect. And even AI has not gotten yet to that capacity. But it's okay. I think we can proceed
So
with the
we
next
will,
question.
of course, that's why I told you this is a start for now, and we rather underestimate than overestimate. That's how the model is trained for now.
Okay, DJ Cropper.
Yeah, Kroba, and then Dr. Onyembo, and then we'll have Eboso, Korean, and Samantha to be our final speakers because you're almost getting to 10. Kroba Karibu, I've seen your videos and you're actually very passionate about this new health model. Tell us what you have for us. Karibu.
Awesome. Thank you, guys. Mine is I come in for context. I come in as a caregiver. My partner is a dialysis patient, and I'm gonna narrow in on that particular sector. Just the other day, we received communication from a couple of dialysis centers where they were going to collect their MOUs/contract from SHA, and they were being siphoned, and it's a very unfortunate situation because unfortunately today someone died because they didn't do dialysis this week twice, and so I would like shucks, I would like just feedback on that because we shouldn't be siphoning medical institutions that are taking care of this kind of patients. And all of us know that these patients all of us, even me, I can't afford dialysis for a whole month. And it's bloody expensive. And so I would want feedback on that. Secondly, we went through the new SHIF part about, and the transplant area was very vague. It wasn't very clear. I'm not sure whether you are capable or you have a team on that end that can respond, but I would want clarity on that because now it has changed from NHIF to SHIF. Thank you.
Yeah, Chairman, you can respond directly.
Okay, so that is for me. Okay, I can
No,
ask.
I think.
You ask.
Just before Nyimbo, so let me answer. On the issue of, I haven't understood the part of siphoning because unless you mean facility has lost money or something, but what I know is in terms of the rate, we have increased from 9,600 to 10,650 to the facility. So the siphoning part I haven't understood, but the issue of
What I meant
transplant.
by that was some facilities are being told to pay up to get their contracts. I'm sorry, I might have said the word siphoning, but that's what I meant.
No, that is unacceptable, and that's wrong. Because what we and that's the reason why I was saying that we have changed the model of contracting. Empaneling is within 30 days if it's a new center, and contracting is supposed to be online. So you don't need to pay anyone. There's no discussion. You don't need even to know who is your branch manager. You fill in online and you send the contract. And that was the idea of the e-contracting. And that's what we are going to do. For physical contracts, it's a temporary measure, but that the e-contracting is what we are supposed to do. On the issue, no one should pay. And I think that we have made it clear that no facility should pay anything for being contracted. And that was the whole idea of publicizing these things on the website and saying this is how you proceed. On the issue of transplant, so what we have done is for the first time, there are certain things that we said we are going to pay for. One of them is pre-transplant evaluation. This was not there previously. And that means that we pay for the tests that are required. For example, the HLA typing and what people are paying out of pocket in NHIF. But for now, we are saying the evaluation and the testing, because they are damn expensive, is around 150,000. So we will pay for that matching. Two, we are paying 700,000 for the recipient, the surgery. Three, we are paying 168,000 for the donor. So you see, previously we were paying around 500,000 for the recipient only. We were not paying for the donor, and we were not paying for the pre-transplant evaluation. Now we are paying for the pre-transplant evaluation. We are paying 700,000 for the transplant for the transplant patient. We are paying 168,000. So if you look at these figures, that alone is 768,000 plus 150. It's almost a million. Previously, the amount was 500,000. So a million now, public facilities should comfortably be able to do this transplant without any challenge, because they used to do it at 600, 700, 800,000. Now, even for private facilities, a million is reasonable enough. And we might get one or two big facilities that are willing to fit in within this price and provide transplant to patients. But what else have we introduced in this space? Previously, you could undergo your transplant and then after that you are let go. What you needed is medication, post-renal replacement therapy. And that was also very expensive for the patient. Those drugs are unreasonable in terms of their prices. But in this new package, we said we will pay 200,000 for your post-renal transplant medication, which was not there. So as a package, if you look at this space, SHA will pay almost 1.2 million. From the donor to the pre-transplant evaluation, transplant, plus post-transplant medication, we will cover. And that's what is in the tariff. I hope that is now clear. And this document, I just want to tell people, is a public document. If you go to the Kenya Gazette, you will just find it and download it. And it clearly spells out even the rules, the what, where to get this, which kind of facilities, the amount, so that when you go to a facility and they tell you SHA is paying for you 600,000, you should be able to say no. The document says it's 700,000, and you report them to SHA and say there's a facility here that's saying it's 600, but what you have published on your tariff is 700,000. So that's the kind of transparency that we are advocating for SHA, where the documents are easily available and everyone can see, and they are in public domain. Nothing is under the table. Thank you.
Yeah, thank you, Chair. I want to bring Dr. Kerama and then Boso. Then we'll have Korean. I have two speakers will close for us.
Thank you very much. So, number one, I have a few comments. I'll try and be as fast as possible. Comment number one, Dr. Mbiti, thank you very much for the work you're doing. I am very proud of you. I've been observing you even when you're going through the fire. You have been rock solid. Asante sana, continue. I think you are the future. Number two, to the chairman, our chairman, Abdi, I thank you for the good work and I wish you the best. I think we're on the right track. To my point number three, when we were younger, when we were singing Yote Yawezekana Bila Nyongo, one of the biggest challenges that we had then was we needed everything to work for the doctor. And actually, on this point, I'm going to be addressing everyone, but particularly my good friend, Dr. Chibanzi. When we were younger, we used to agitate and say we need two things. In fact, my colleague, Dr. Victor Ngani, used to say two things. We need to make sure doctors are paid. And number two, we need to improve healthcare. But what am I seeing now? I mean, at that time, we made so much noise, and our objective was to bring the conversation of healthcare to be front and center. And most of us here who were in the streets and singing those days, and all we wanted was to make sure that the conversation of healthcare was front and center. And President Uhuru immediately thought about UHC, and most of the conversations that started in 2014, and eventually when our colleagues, Dr. Uma Oluga, took over, the conversations became stronger and louder in healthcare. And now we have a head of state who has made healthcare their number one agenda. For me, that is extraordinarily gratifying. But I'm quite concerned that the direction we are taking, we have become very, very, I don't know which word, very unfriendly to the entire topic about healthcare, to a point that if I
Is Onyimbo still around?
Yeah, amepotea.
Mbiti, we can move
can
to
you
the
hear me?
next.
Please tell me you can hear me.
Oh, yes.
Yes, we can hear you now.
And the way I was talking for a long time, let me start again. So where did you hear? What was the last thing you heard?
Answer tu
That
mahali
we are not
unaona.
about to see.
Penye
So,
ulikuwa unasema Dr. Chibanzi or something.
oh my goodness. So I was saying, I have faulted our bosses, Dr. Davji and team, not because I think it is the noise that we made in 2012, 2014, 2017 that made it possible that healthcare is now a conversation front and center. And you can see the union is now actually working for healthcare. You can see Abdi is there as our boss in SHA. We can see Dr. Thuranira in State House. I think we have succeeded in what we wanted. We said that being in the streets is good, but being in the decision table is perfect. Now we are in the decision tables. But I think even when we are making decisions, most of us don't trust the decisions that we are making. So I want to go to the topic. The third topic, or is it the fourth? The fourth topic is about NHIF.
Umepotea tena.
We have lost him, eh?
What am I going to do? Can you hear me now?
Yeah, you're speaking about
Yeah, we can
NHIF.
hear you now.
So one of the reasons why I am happy about the NHIF being cancelled is NHIF had lost its character. We know that there is a social health insurance where the many, the rich will contribute so that the poor can also get. That's a social health. And so generally, universal healthcare should be funded either through contributions or taxes. And therefore, the people who have more will give so that those who have less can get. And so the character of a social healthcare is not that you get a commercial product. Now, NHIF, from somewhere in 2013 or 2014, they started giving commercial covers. So you have a social health cover, which is giving commercial products, and we call them enhanced covers. I think the reason why we're even calling it a social health care is to remind us that this is a social health cover and not a commercial cover like the Jubilees of this world and the Madisons of this world. And so I think this is a great distinction. And I think Dr. Ouma was asking why, and the man from Pokot was asking that why is he not getting the comprehensive cover he used to get. What the man from Pokot was getting is something called a commercial cover. You give money and you get value for money immediately. What SHA has to do is get 100 shillings from 100 people and then cover 300 people using those 100s. So 100 people contribute so that we can cover 300 people. And so it is not a commercial product, it's a social program. And that is a very great distinction, and I wish Chibanzi would.
We're running low on time, so because the other speakers had some questions, and I think Dr. Abdi had gone into depth about that. So
Let me finish there. I can just finish by saying this. Dr. Abdi, my anxiety is why did we choose to use contributions instead of taxes? I feel like a contribution funded UHC can be a challenge. I think that is the short question. Thank you.
So just to answer that short question, thank you for your contribution. We have done a mixed model. And let no one lie to you that one model of financing is better than the other. Social health insurance is usually the best method of providing UHC. But for us, what we have done is we used both tax and contribution. Tax to cushion the contributions, because we know contributions alone will not be able to give us all the benefits and the tariffs that we need. And it will not also add the rights, some of the rights like emergency. So for that reason, we have a mixed model, and I think that is what will make us sustainable, because you also don't want to burden one part, which is either a contributor or which is just tax funded. And let's keep in mind that our health system currently, as it is tax funded. Because people, sometimes confuse these things. As we speak today, the Ministry of Health gets a budget, counties get money. Actually, most counties, because health is devolved, use the highest percentage of their budget goes to health. But you tell me whether that is giving you any value, number one. Two, whether that is sustainable. How much more do we need to pour into that line of thinking for us to get value out of it? So this model also, the other thing that this model has done is, other than being tax funded and contribution, is we have made the financing to be the financing is output-based financing mechanism. So it's not input. It's not brick and mortar. It's not equipment. It's not. So what we want you is, you provide the service, I pay for the service. And at least I am sure the patient has gotten the service. So I'm paying for what the patient has gotten, which is a service, a healthcare service that they needed. But if we move towards the input financing, which we have and have been having for the last 60 years, we know the outcomes and we know the results. Thank you.
Thanks, Doc. We have been the 2 hours were to end at 10, so I have 4 speakers. I want to bring Aboso. I know he has a lot to say. He is quite insightful on these issues. And then I'll bring Korean. then the two doctors. Boso, karibu.
Okay, thank you very much, Dr. Nditi. Number one, I'd like to tell Dr. Abdi, who's my friend, and we've had several discussions on this shift right from last year, that I'm still not persuaded on why NHIF could not be made better, but it is what it is. Now, on the first issue is on the issue of transition between SHIF and NHIF. When we were giving public participation views in February or March, one of the issues I raised in my memorandum to the ministry was a transition, and I pointed out that health is a very important function, and that we have to be careful that we do not allow the NHIF to be wound down before we have really transitioned properly. I think I even proposed that we could start launching the social health program by region, so that it can be tested in one region, then another, and whatnot, so that there is no interruption. I don't know if that was ever really considered, and what came out of it. And even right now that anyway the NHIF Act will stand repealed next month on 23rd, but the services and what NHIF has been doing really is being taken up by SHA. At this point in time, because of the hiccups we are getting, is it possible that the SHA board can still continue providing the NHIF services even as SHA, exactly as they were, and roll out this SHIF now regionally, so that we don't have a situation where we are having these hiccups. Number two, the issue of cost versus contribution. Now, generally, in public health, I think when we study public health and I think even in law, health is not considered a public good. Strictly speaking, health is generally considered one of the things that you should pay for privately, but government can be involved in providing health and providing health policy and regulating. But here we have a situation where we are essentially making health a public good. There are good things about it and whatnot. But the problem with that is we are making not just the healthy to ensure the sick, we are actually making the wealthy to pay for the poor, and it's not government doing it. It is actually an individual who's taking care of the health of the community, and really that in itself, I think, is quite offensive to. I know it's been said as though it's a good thing. It's being said as though it's something to celebrate, that we are taking from the rich to give to the poor. That's not okay at all. And I would like to just point it out at this very stage, that it's not okay to take from the rich people or those you consider wealthy in some way to give to the poor. It is government supposed to provide these services through taxation or through taking care of the indigents as it is and whatnot. Kenya is not the first country to have social health insurance, because I know India, Singapore, China have a form or another of the same. I think the Nordic countries provide for this through taxation, but Singapore, India, and China all have a social way of sorting it. But even then, they have categorized the health, the different packages, such that the benefits, so that there are those the poorest who have their own fund that the government invests more in it. Then there is a middle income, and then there is a very high income. And it's because it's just, we're talking about equity and being fair, but it's not fair for one person to be paying 240,000 per year, or one household, and then they get the same as someone who's paying 300 bob per month. It's not fair, and that same that they are getting is really not really adequate healthcare, if I should say so, because there's a maximum that you can get from it. As you pointed out, someone on dialysis will only get a maximum of 1.2 million. So someone who probably would want more, maybe would want even to go out of the country, or would want to get private healthcare even, and can afford it, why are they still having to pay all that money to SHA and whatnot. Then the issue of the means testing and the differential ways in which salaried people versus non-salaried people are being made to contribute. Salaried people, it's being taken from their income. Non-salaried people, and I think there was some misrepresentation that the means testing is for indigents. No, it is actually for anybody who is not on a formal salary. Now, I know very many people who are not on the formal salary. I don't know, someone is. Can you hear me? I know many people who are not in the formal system, but they make a lot more than the formal people. A businessman, for example, who's not employed, that person could be making $1 million a year, but then you will use a means testing tool for them, and through the means testing tool, they may pay much, much less, and whatnot. And aside from that, when you take from the salary versus from means testing, what you're doing is you're taking my gross before I have paid school fees for my children, before I have paid my rent, before I have paid anything. You're taking that money from me. When you use the means testing tool to determine the items we have in the house, like a TV, 2 toilets, and whatnot, those are items that we purchase after we have taken care of other basic needs. That's not being considered. How did we arrive at 2.75%? Why not 3%? Why not 4% or 20%? Why not 1%? That 2.75% was determined, I know, before even this government got into office. When it was still campaigning, they talked about 2.75%. So when 2.75% is implemented now, it seems to me that there was no mathematics that was done post getting into government and seeing the realities, that this was just transferred from the manifesto into the regulations. And really, that's not how we should be dealing with public affairs, because these are people's individual monies, and these are people who are already struggling. On the question of data transfer, again, I wasn't really persuaded, and I was a bit, I frowned upon the fact that the position seems to be that if someone feels like their data has been infringed into, they should go to the data protection office or go to court. I don't think that really should be the attitude, because essentially, data and privacy is very important, especially because we are going to run this data over a system that is, one, not being managed or not being owned locally, or that has not been developed locally, that will have access to third parties, that we don't really know what other things will be done with this data. And so it shouldn't be a casual approach where a gazette notice is just put out, in fact, without public participation. And by the way, I don't think the parent act that authorizes the gazette notice contemplated a situation where NHIF data would be automatically transferred to SHA, because there's nowhere along where and the issue of data is talked about. So I think it's something that SHA needs to relook at. And if the attitude that SHA is going to have on personal data is to that the way it is coming out, then we are even more worried that that we may not really trust now SHA even with the data, including even the one that we give consensually. Then Dr. Abdi talked about the issue of regressive NHIF and progressive SHIF in terms of the contributions and whatnot. And I'm starting to feel like SHA is delving into very deep and controversial political and economic issues that even the world generally struggles with. SHA is talking about, I mean, this whole idea that is coming out is that part of what is underlying SHA, which should just be an entity dealing with health, is talking about communist aspects where rich people are taking care of poor people, or socialist aspect. They're talking about sort of like determining the taxation regime and sort of trying to determine whether a tax is fair or not fair and whatnot. And I'm starting to feel like health is too risky. Health as a public thing is too risky to start subjecting it to this kind of experimentation, where we are trying a new way of taxing and whatnot, or we are trying a new way of managing consumerism. Because I think I heard you talk about how we are going to talk about the commodity prices and whatnot and how to bring them down. I don't really think health, especially health that covers the whole country, is the place for us to try those things, especially not at a go. So I think those are the concerns that I have, that SHA should try and steer clear from trying to determine taxation issues, or how many people in the formal sector contribute to tax and whatnot, because we will go wrong. Tax is so broad and so such a serious political question, and a global issue around the entire economy, that we might collapse healthcare because of trying to experiment in such things. Thank you very much.
Thanks, Mwalimu. I think, Chairman, you will respond. I wanted to bring Korean, alafu Daktari Mohammed, then I'll bring Chibanzi and our KMA chairman as the speakers. Korean, I hope, Chairman, umesikiza, you've heard what was saying. Because we share actually the statements that he has is exactly what were my concerns.
It's okay. I know Boso is my friend, and he's on a speed dial, so he can call me anytime, any minute, and we have
But
the
more
fast.
importantly, I was hoping also when we raise such issues, I think they
Oh,
should
you
be.
know, I have noted. You see, those are, what did he call it? Philosophical, political taxation. You see, for me now, I was trying just to answer the issues that are the day-to-day things in terms
Yeah.
of how do we address the operations in terms of how do we make sure the transition is much more smoother and we conclude as fast as possible in terms of the transition,
Yeah.
and then how do we address the hiccups. But whether health is a public good or not good, whether the rich should pay and the poor should not pay, you see, those are now things which are a little bit more need discussion.
True.
Yes.
So,
Okay, I think
we'll
you're
be
using to
having this.
celebrate. They are the things you're using to celebrate SHA, such that we had to respond to them. You can't benefit from them, and then when you need to answer on them, you want to run away and say they are political questions.
True. All
Thank
things
you,
there,
thank
you
you,
you have no idea.
Clarence.
I've tried very much not to be philosophical and political.
Okay.
I'm very itched, but again, given the scope of the space today, we'll have such discussions and more.
Yule tukiwa mtoto.
Yeah. So
Also,
Korean, you
we will
can.
organize this, me and
I
you.
want Korean to speak, and then Daktari, then Chiba. We are closing. Then we have three doctors to close for us. Korean, go ahead.
Okay, thank you, Dr. Biti and Dr. Abdi, for sparing the time. Mine is very short and precise. I work with an NGO that deals with the faith-based organization and government facilities, mostly supporting them in terms of ensuring they have good processes and the likes. Now, my concerns are, especially to the private sector. Recently, I've visited most of the FBOs in so many counties in Kenya, and they were already struggling because the former NHIF owed them a lot of funds as part of the services provided, but they have not received the reimbursements. Now the challenge is, now we have brought in a new system that is in place. We don't know when the services that these facilities are offering, when should they receive the reimbursement of the current services that they are offering, bearing in mind the contracts that had been extended to 30th of September, they have already expired. Some of these facilities have not even signed the new contracts with the SHA. So I am wondering what will happen during this period. I know the system is not really so much functional in all the facilities. It's the patients who are really suffering in this health facility. So I would like Dr. Abdi to clarify what's the position the government holds for private and FBO facilities in regards to reimbursements of the services offered. And then again, there's this thing called digital health superhighway. It's a good system, but unfortunately, we have put in a seat cart in front of the horse. Because for one, for SHA to work, it rely more on this particular superhighway. But then there are counties where more than 50%, because I have been virtually worked in more than 40 counties, we have counties where FBOs and private facilities offer almost 50% of healthcare in those counties. And now you talk about digital health superhighway as a major or maybe a part and parcel of the success of SHA. How is the government going in place to ensure that the FBOs and the private sector has been interlinked with the digital health superhighway, which calls for software and the hardware integration in that? Then lastly, it's about the two funds, the PHC funds and the emergency chronic fund and the like. These are more of the tax financed form. Now, recently, the government allocated very little amount to the two funds. My worries are to the providers. Should they still, what guarantee can there be that even after providing, in this case, I'm talking about the FBOs and the private health facilities, what guarantee is it there that after offering the care, be it in level 2 or level 3, they are going to get reimbursements from these government-funded projects or maybe programs? Whereas already we can see from the beginning, the government has performed very poorly in terms of financing the two programs. The last question is, in about 2 weeks or maybe a month, perhaps this SHA will be thrown out by the courts. And now Kenyans will be operating with no insurance in place. So what measures are there in place to ensure that patients do not suffer? Because truly, when you go on the ground, last week, I went to Kiambu and I found a patient who has been receiving antihypertensive medication in a mission hospital free. Now they were being told to pay 2,500, and that old lady was almost begging the cashier, "Can I at least take for a week? Then afterwards, whatever happens, God will be for me." So health is not something that maybe we need to have a trial and error. There are real people who are really suffering on the ground. Perhaps on top here on the news, not every story will be on the news that patients are suffering. But behind the curtains, we have so many patients who are really suffering because of this unclear or maybe hurried. It's a very good maybe form of financing healthcare, but it's too much rushed. And we are only considering government health facilities. But there are we have a sub-county, I will not mention it here, where we only have 2 government health facilities. Now, we expect that community in that entire sub-county to receive care in only those 2 sub-county government health facilities, which are also poorly funded, without drugs, without enough healthcare workers, infrastructure is broken down. So Dr. Abdi, if you can respond to that, I would be very grateful.
Thank you. I think you have asked very pertinent questions which need to be answered. So the first thing, I am in agreement that NHIF owes people a lot of money. And that was one of the problems that we have had with NHIF, the sustainability bit of it, because the consumption from managed schemes was way more skewed than what was available. So for that reason, it has been a challenge in terms of providers being paid. Two, the system is working in majority of the facilities. It's the opposite of what you have said, which was that there is no system in all the facilities. But actually, it's working in the majority of the facilities. Even if you now walk to KNH, you will find it's actually working. Three, on the same issue of the system, yes, definitely, we will connect private and mission hospitals to the superhighway, because there's no one uh, who will be outside that superhighway, and we have enough time to connect everyone between now and December and even next year, depending on how quickly the private and mission will connect. Because the HMISs that we are using for the public facilities are all connected to the digital superhighway already, as we speak. And there are three of them: AFKE, Kenya EMR, and TIBAB. But also to declare that anyone who wants in the private sector any of these three HMISs will get it for free. It's available. It's part of this digital superhighway. So if you have a facility and you need one of these HMISs, you will be given for free. In terms of whether now this is now where the public and all of us come in. So there is the three components. The two tax funded, we will need the help of Kenyans to make sure, first of all, there is enough allocation. Secondly, there is release of those funds, because all other sectors receive their money. Why should be health should be the only ones that have delays? Because security, education, what, those get their fair share of, and even more. Education receives up to 700 billion annually from the exchequer. Health is the first time that we are saying we need something extra other than what was previously budgeted for. So the second thing is, because we are collecting now premiums from both formal and informal, so there will be enough resources. There will be a sizable resources at SHA, but more importantly, the administrative cost is capped at 5%. And secondly, we don't have the leisure of investing. So the work is just to pay providers. So we can't do land and such things that NHIF used to do. We are aware and we are alive to the fact that private and mission hospitals play a very crucial role in health service delivery. If we looked at our press release on Sunday, it was after we had a discussion with those providers. And I can tell you, majority of them have already signed the contract. So we don't have any preferences on who provides the services. As I have said earlier, it's output-based financing mechanism. So it is who provides services is who is paid, not a budgetary allocation to specific facilities depending on the ownership. So for us is money follows services. that the patient has gotten. So you are saying a county that has two public sub-county that has two public facilities. I can tell you Nairobi, I think it's only 15 or 17% of the facilities are owned publicly. 85 or 83% is in private and mission hospital hands. So we are alive to those facts, and we know there's no way you can run health without the private and mission facilities. There are plans. There was a payment that was being made today, if I'm not wrong. Then there will be subsequent payments, which was the pending bills for NHIF, which will be done next week, and hopefully another one the other week. So we will have, maybe in the next 3 to 4 weeks, we will have 2 to 3 tranches of payment for pending bills from NHIF. I think I have tried as much as possible to
Actually,
answer this.
maybe
Yes, yes.
the last question was,
Mm.
in about 2 weeks or 3 weeks' time, the court will have a ruling.
Oh, okay. The court.
Now, as
Okay.
yes, now we have service providers who will be operating with a contract. They have just signed a contract recently with SHA. But now, the previous contract with the NHIF, because of the act, it's already null and void. Now, we are working in a void that we don't know. Do you provide a service without a contract? Or so what plans are there?
So the plans is every facility has been given the leeway to sign the contract or exit. So what you need to keep in mind is not every facility is run by the owner. So some facilities, it is the administrators who are in charge who have to get approval from the owners whether to sign or not to sign. But on the issue of the court, I think we allow the court to make that determination. But if you have read the ruling of the High Court, you will see the High Court was very categorical in terms of what the issues were. So they talked about, I think, 3 issues. One was the issue of emergency. And for me, that was just an error because they said and thought that we will deny people emergency services because they are not registered. It's very clear in the regulations and the laws that emergency is for everyone, irrespective of their registration status and their. So I think there was an oversight in that from the ruling. The second thing that they talked about was the issue of public participation and sensitization, and they said it was not adequate. They did not say we do not do public participation, but they said it was not adequate, that we should engage more and sensitize the public. Then the other thing that you need to keep in mind is there will be many more lawsuits. So if you say we will not proceed or we will not to do anything, then you will get stuck because everything will be canvassed in the courts. So it's the courts who will make that determination, not for us to say we can't proceed because there is a court issue. So the court will look at what is in the public interest, where are the issues that need to be addressed, and what are what is coming out in terms of the interest of the public in general. And you have a chance to be heard throughout. So you have started from the High Court, you are in the Court of Appeal, you can move to the Supreme Court. So you have that right of appeal process to go through the court for it to make that final determination at the apex court. So for me, I would say that let that take its own trajectory, and we'll find out how that ends up. Thank you very much.
Thanks, Doc. I think we are way past our time. Want to finish latest by top of the hour. I think we'll have subsequent spaces. I also work in a mission hospital. What Korean is saying is what we're experiencing right now. Like I said, we only have 4 patients. There are a lot of logistical issues. The hospitals themselves are not very willing to admit patients for the fear of losing out. Like our facility, NHF was us quite some huge amount of money, not even to talk about Linda Mama. So I hope we'll have these subsequent conversations, purely non-political, very objective on it. I want to bring my Dr. Chibanzi, and then I have my KMA chairman here, and then we'll have the two Dr. Strange and Mohammed as we wind up. Chibanzi, karibu.
Thank you. Well, I think I just say that I've listened to my good friend Abdi, and we've had conversations before, and I agreed that we are divergent on how this entire thing is being financed and being run. But nevertheless, I'd keep it very simple. I don't want to discuss so much. I think the question I have is first is clarify the NHIF comprehensive cover came into being when civil servants relinquished their 3,000 medical allowance. There used to be a medical allowance before. So there was a 3,000 medical allowance plus the 1,700 that was being deducted from the salaries. So it was not 1,700. So the total contribution from civil servants per each civil servant was 4,700. And that would perhaps explain why they were getting much more benefits as opposed to other Kenyans. The issue of inequality and equality is a whole different discussion and debate. But having clarified that, I had Abdi say that the deficit was 3 billion because he said expenses were 9 billion, contributions was 6 billion. So the question I have is this. How much would it have cost? Despite the 3 billion, it will have meant then if you want to cover this deficit and the civil servants, according to your reasoning, were paying less than it was coming from the other pot of other Kenyans, if you were to increase for the civil servants to cover this deficit, how much would you have increased? One, and then two, if you would have decided that you were rolling out this comprehensive cover to the entire population, how much will it have cost? Those are my two questions. Simple.
I don't know if Abdi is there. I think he can respond because they were quite precise
So,
questions.
okay. So you, of course, if you needed to cover comprehensively the civil servants, all the other schemes that were loss making. By the way, it was not just civil servant. There were 96 schemes. So it's not just civil servant. But more importantly, unless Chibanzi knows something that I don't know, not all civil servants earn more than 100,000. So 1,700 was for doctors and other cadres, other higher job groups. You know, there are those lower job groups, KLM and what. So their contribution was not 1,700. It was the usual 800, 400, 600, 1,000, 1,200. So you needed an extra 3 billion for you to be able to cover comprehensively. So if one around and the civil servants were 135 members, thousand, with their dependents. The rough estimate was around 400, or make it even 500,000. And then make 10 billion as their requirement. So I will do for you the find X. If 500,000 consume 10 billion, how much will 50 million consume? That will give you the figure that you need to give that kind of comprehensive cover to the whole Kenyans. But generally speaking, and the reason why that was, if you take that route, is remember civil servants were getting benefits and they are accessing it through the private sector. If you limited them to public sector, you wouldn't need uh, more than the 6 billion that they were consuming, that they were paying. You will need actually much less. Why do I say so? The reason why I say so is if you go to the private sector, for example, to any major hospital, and you go for normal delivery, and you take your wife and you say, I want her to deliver, you can pay 4 prices for the same process of normal delivery. 4 prices. I did not say cost. Please underline the word prices, not cost, because it depends on where your wife will sleep. It is the hospitality aspect that will determine how much you will pay. If you go to the general ward, the delivery will be maybe 50,000. If you go to semi-private room, where you are sharing the washrooms, you will pay 100,000. If you go to private room, you will pay 150,000. If you go to the presidential suite or whatever luxury rooms they have, you will pay 200,000. You realize that this same woman would have been delivered by the same nurses in the same labor ward using the same drugs, but the only difference is where they have slept. So the civil servant scheme was expensive, or they were consuming more than they were paying, is because of that kind of access, where someone says, I have a limit of 1 million, so let me go to the presidential suite for my treatment, rather than a general ward, or rather than going to a public facility. That's what made it expensive and unsustainable in terms of what the NHIF was paying. So we will not go that route of find X. If 500,000 is using 10 billion, then 50 million will use times whatever. It will be irresponsible of us. And that's why we have these benefits and tariffs. And that's why we are saying this should be available in both public, private sector. So if now you need those kind of hospitality aspects of those services, then you should be able to top up either from your pocket or from your private insurance. But for us, to begin with, we want to provide the basics, and certain aspects of this package don't need the hospitality aspect. Like if it's dialysis, it's dialysis, and that is fixed for everyone, and they are able to find it from anywhere. Public private mission for the same price. Cancer, similar. Radiotherapy, PET scan, similar prices without having to top up. So I am not saying they did not concede their allowance. What I'm saying is their allowance plus their contribution was not enough for what they were asking. It was not sustainable. Thank you.
Thanks. Yeah, we really. I wanted just to bring Keme chairman, Dr. Kingodu Karibu, Alafu, Mohammed, and then Strange. And then we love co-host. Karibu, Doc.
Yeah, thank you very much for the organizers of this space. And I think one of the most important principles is that we must continue discussing. As you know, the KMA board person was not put into the board until recently. So for us as KMA, we can say we have not contributed to...
Say until I became chair.
Yeah, so we know that the KMA person has not been, and therefore the KMA input has not been considered, and that's why we are having some of these problems that we are having. So let me tell Abdi that no one should die for a transition, so that people can say they have transitioned from SHA to NHIF in one day. And I think from the realities on the ground, we should not run away from the fact that this transition, the change management was poor. So let's see how to solve that. Then, secondly, of course, the Robin Hood principle. The OECD countries have agreed on tax principles which constitute of equity, efficiency, simplicity, and transparency. The SHA system goes against all those. In terms of equity, they keep yapping that 2.75% is equitable. It is not. In the principles of equity, in TAN's principles, you have an inverted triangle such that the people who earn more, they get taxed at a lesser percentage. Of course, the total amounts will be less. Of course, we have proposed that they cap it at a certain figure, but at the end of the day, we think that we should not even be paying on a gross salary. And why should we not be paying on a gross salary? The government, the Kenya Kwanza government, is in charge of the country. It has caused the cost of living to go high. So the gross income of any person does not reflect their means. Over the last 2 years in the Kenya Kwanza government, the bank interest rates have doubled. What does that mean? Some of us who had credit facilities and mortgage facilities are paying double of what they used to pay in the previously stable credit facility and mortgage interest. What does that mean? It means that this gross thing that they are talking about is nothing. So secondly, the government is also in charge of things like education. They're the ones, if you have poor quality public education, people have to move to private education, not of their own making, but as a result of the government. So for the government to come again and to charge extra, so you become the government supporting so-called other people because you are perceived to be rich. That's I think triple taxation. It's not even double taxation. Thirdly, they say that you pay as individuals but benefit as a household. I think that is Robin Hood. That's Robin Hood. You've taxed the father, the mother, and the 25-year-old child, but when you come to claim for benefits, you're being told 900 shillings for the household, but they have charged you for 3 people. So I think that is not fair at all. And for this transition now, the current one that is having the facilities, it's obvious that the system is not working. And for people who are seeing patients, and they have experienced this in 2019 when NHIF switched off the systems, is that you will not be paid for things that have not been captured by the system. So a system failure makes you a contributor you become like CSR of government. And that's why a lot of people, and you have had some of the faith-based organizations saying that they will not see people until they pay, is because of previous experience. So I think they should move fast to solve this transition thing, which we as providers had said that they should take over a year or 2 to try. But I think they just want to change quickly just to say they have changed quickly. So I go back to my finally OECD tax principles. Equity, you should have an inverted triangle. The people who earn higher should pay a lesser percent, or at least according to our propositions, we say you either cap it or remove it so that it be fully funded. Efficiency, we need to minimize economic distortion of these taxes. Simplicity, the means testing instrument is not simple, and it is not verifiable. So this goes against the trust. So when finally transparency, the means testing instrument is not transparent, because I can come, community health worker comes, I tell them right there that I have a thatched house, and you get less payment, of course, because of the economic conditions that are as a result of the government. So my advice to Abdi, you either cap the deductions or remove them, because this is extra taxation that we cannot handle. Then secondly, we need a transition period so that people do not, this thing will be thrown out based on access to patient care, because people cannot access because the system is not working. But overall, finally, just to say that I have looked at the overall system of the digital superhighway, and I think it is a brilliant idea. But some of the issues that are not being addressed in a small component of this whole thing called SHA are the ones which are messing up a brilliant idea. So I think they need to be looked at, and we'll be passing our message through our representative at the SHA board. Thank you very much.
Thanks. Before Abdi you respond, I think Kush also had he was here before and he had an idea on something close to what KMA president has raised. Maybe Kush, you can have 2 minutes or 3, and then we bring Dr. Strange and Mohammed to close for us before we give the chairman.
Hey, hi everyone. I hope I'm clear and audible. First of all, to Mbiti and especially to Dr. Abdi, thank you for giving us this time to be able to discuss such a critical topic. So I'll start by making a general comment. Dr. Abdi amesema anaogopa philosophy, so sitampeleka mbio sana on that, but I feel like in this whole discussion, there is something that has never been clarified in our society on how to deal with healthcare delivery, healthcare financing, etc. Just to buttress the point that Dr. Eboso made, most societies consider healthcare to be a private good, that you pay for your own healthcare. The government is there to regulate and cushion the less fortunate in the society. We have never really clarified where our position is as a Kenyan society is on this. We have a mishmash of both. We have a government program that is supposed to be competing with private healthcare facilities, private insurance, etc. If you were to look at the split between public and private facilities in Kenya, it's around 43% public facilities, 37% private facilities. Comparing this to like more advanced healthcare systems, for example, the ones that are doing universal healthcare, especially. If you look at the UK, for example, with the National Health Service that they have, the National Health Service operates 87% of public facilities. 13% is left to the private facilities, and none of those facilities are involved in critical care, in emergency care, in basic care, in primary care. All those components are fully taken up by the government. If you go to Netherlands, it's a similar thing. You have private entities, facilities themselves, insurances that are operating under a strict regulation of the government. The government actually makes sure every resident in the Netherlands pays healthcare premiums. If you don't pay healthcare premiums, you're actually fined. But then again, if once you pay the healthcare premium, you're guaranteed all levels of basic care. If you get into a car accident, you get all the care that you need, and you go home. If you are to deliver, if it's a pregnant woman delivering a child, they deliver the child and they go home. Comparing this to the opposite, which is the best example is the United States, where we don't have, there is no major role for the federal government or the state government, the individual state governments in actually providing public health care. The government is strictly involved in regulation and protection of the less fortunate, the elderly, the homeless, etc. So in Kenya, we are kind of in two minds about it, and this is coming out in all these discussions we're having about the SHIF and the primary healthcare fund, where you have a mandatory fee. At some point it comes out as it's mandatory, but then you have to register. But then there's also an element of it that is covered by taxes. But then the cover that you're getting that is mandatory is nowhere near enough to cover basic healthcare. Telling a woman that you're going to cover her 10,000 shillings to deliver a child, that 10,000 shillings will be over by the time the woman gets to the delivery room. Will not even cover the charges for the delivery itself, postnatal care, etc. So I think there we have a big problem as a country, and not necessarily, this is not necessarily to Abdi as the chairman of SHA, but I think because he has this privileged position as the custodian of healthcare financing in Kenya, he needs to really take this into account and consider it. That leads to the strategies that we should be taking to reduce out of pocket and cash paying, because as you all know, probably 70-80% of Kenyans are one medical emergency away from poverty. I work in a critical care environment where I see this every single day. Someone comes in with a stroke, the whole family is bankrupted within a matter of 2 weeks because they cannot afford ICU charges, they cannot afford the critical surgery that the patient needs, etc. So as we're discussing all this, it needs to come out clearly that the role of this social health act is to reduce the amount of cash paying that we're doing. I was taking a look at the document called Tariffs to the Benefit Package under the Social Health Insurance Act that's in the Ministry of Health documentation. I'm not sure if that's the correct document to be looking at, but that's what I found. And as I'm just scrolling, I'm seeing many places where you have limits of 4 visits for outpatients, limits of 900 per person, limits of 2 CT scans, you see. So you're essentially taxing the population and putting them in a situation where they are paying a significant amount of their income. If you were to compare it to, for example, private insurance options, and giving them probably like 30 to 50% of what is available in the market. This is not acceptable. It can't be acceptable. Again, another point that Dr. Iboso raised, as well as KMA chairman raised. This strategy, this Robin Hood strategy of equalizing through inequality, because there are people who are rich in the society and others are not as rich in the society, we have to make the rich pay for the poor. Not only is that not beneficial to the society as a whole, because the rich will start finding ways of avoiding paying that, paying their shares as they are required. You're also introducing, you're introducing this idea that there is a class that should be paying for another class, and you're introducing a whole new class war that I don't think is beneficial when you're discussing healthcare matters. And, I'll just raise one or two issues that I've seen in the 3 funds, the SHIF, the Public Healthcare Fund, and the Emergency and Critical Illness Fund. Most of the things have been touched on by the previous speakers. There is the issue of the poor implementation. It was too rushed. I wonder what was the rush to roll this out essentially overnight, when you could have had a staged rollout to make sure all these teething problems are being sorted out as we go. That was really poor. We have all these legal and constitutional battles that are going on. I won't comment much on that. There is the issue of the mandatory nature. You're making people pay essentially by force. You're targeting the salaried individuals because you can get to their money. You're creating means testing tools to find ways to make Mama Boga and Boda Boda pay their share. But not only are we not having enough coverage for the different medical emergencies and medical illnesses that you have, we're also having a clash. For example, if you were to look at that document in the maternity and newborn and child health services, the same charges that are supposed to be being covered by the public healthcare fund and the tariffs that are being offered are the same ones that are being offered under the social health insurance fund that now is supposed to be replacing NHIF. So if I'm paying taxes, I'm legitimately entitled to the public healthcare fund. Why then am I being forced to pay for SHIF and getting the exact same service at the exact same price? It does not make sense to me. That overlapping coverage is, I don't know what I don't know what was the idea there, but maybe you can clarify, Chairman. The last thing and probably the most important point I'm going to make. The problem with NHIF was not the structure. Maybe there were issues that needed to be streamlined. Maybe there were issues that needed to be upgraded or reformed. But the primary problem was not the structure. The primary problem is corruption. Just like in any other public institution, we have people who are working there who are buying apartments in Lavington, who are taking money here and there, taking money in sacks, etc. So we can paint the boat, but if the boat has a hole, it's not going anywhere. So I legitimately see us in a situation where by the time it's getting to 2025, 2026, Chairman Abdi, I'm sorry to use your name, but I would hate to see you in a situation where you're being summoned by ECC because 5 billion shillings has grown some legs and disappeared. So how are we going to deal with these issues of corruption? We might talk about this digitization issue and everything. Already the digitization has a question mark about the tendering that was done. If you were to look at the other places that have been digitized in the government, we digitized the payslip systems, but we still have ghost workers, we still have double payments, we still have all these problems. So cosmetic solutions to a systemic problem will not get us anywhere. That's all I have to say.
Thanks, Kush. I think that was Chair. You have to respond to Kush and the KMH. I think they had a synchronized opinion, which most of us actually share, and they're actually very, very, very important. So you'd give us your. I want us just to sum up because I don't want again to bring. I want Mohammed to say something. I hope Chairman is noting them out as he responds to them and he gives his closing remark. I think that will save us time. Moha.
Hello everyone, habari zenu. I hope you guys are okay. Thank you, Dr. Mbiti Days, for this platform. Thank you, Dr. Abdi, for being. This is one of the rare occasions where we get someone who is on the decision-making table, allowing us to have room for discussion. And I think this is it's something new that Dr. Abdi has brought. So my questions are not many, just 3 questions. One to Dr. Abdi is, how long are you anticipating these teething problems to last? And if you can give us like an estimate time frame of when this system will be working flawlessly. The second one is in terms of financial projections, in terms of finance and number of registered people. What are your projections for this quarter? And are the projections enough to cover the NHIF debt payment, as well as payment for services under SHA, without accumulating any debt to SHA or overburdening the facilities that were already having NHIF debt with now new debt to SHA? And finally, this is more of a personal question to Dr. Abdi. What is the one thing you like most about SHIF or the SHA? And what is the one thing you would have changed individually? Thank you.
Thanks, Chair. I think you can respond, and give us. It's quite late. We've been here for more than 3 hours. Perhaps we should have started earlier, or also have follow-up sessions. Karibu.
No, every time I go for this kind of discussions, it takes longer than expected
Expected, yeah.
because with time people learn the questions reduce in terms of what needs to be clarified. So just to answer the last, we, as I have said, that there are payments, NHIF debt payments is being made, which was supposed to start today. I think some facilities will receive their payments early next week. There will be subsequently regular payments to clear for the next 3 to 4 weeks. Not to clear fully, but to make substantial payments to the facilities for the pending NHIF debt. Then there is the issue, yes, for SHA. So there is the two funds, primary and emergency and chronic illness. So those ones are tax funded. So we have already 6 billion given in the account. And then we expect subsequent allocations in the supplementary budget. But in terms of collection, our expectation is because we are looking at 9 months. So our conservative estimates is around 70 billion for the 9 months. So if you divide that into quarters, you will find is around 16 to 17 billion quarterly. Then, in terms of what do you like about the current SHA? Two things. One, we are operationalizing emergency as a right. 14 years late, but we start from somewhere. For me, that is something that I'm really happy about it. That for the first time, at least, you are not worried about emergency treatment when you are involved in an emergency situation because you don't have money or anything. Second thing for me is the primary health care. So the primary health care also is something that I would say will touch many people. If you address primary health care properly in terms of service availability and provision, which I'm not saying will be immediate, like this first quarter or second quarter. It will be a progression in terms of that provision, and the quality of it will become apparent as time goes on. Is available to every Kenyan just by registering, and that will address 80% of our healthcare needs. If you look at generally population health, it's only around 5% who consume high-end tertiary care. Majority of the people don't need expensive tertiary care because you will realize, even looking at yourself and your life, when was the last time you were admitted and you needed dialysis or you needed surgery or you needed, you will realize majority of Kenyans would say no, they can't even, they have never needed those things. So our consumption is usually, it's around 5% of the population who will need very highly specialized services. The second thing that I would address, what would you like to change? For me, I would like the courts to allow us to implement the laws as we had designed, and more importantly, to see that we become a little bit more patriotic and stop this assumption that we will always be the ones who are earning a lot, and we will always be the ones who will be deducted gross 2.75%. This assumption is what some people need to just get out of their mind, that anytime anything can change in this life, and paying out of pocket is not sustainable. And someone mentioned and say, I can't sustain dialysis for a month. That's the reality for almost 99% of Kenyans. Paying a million plus annually is not an easy work. So prepayment is the best method in terms of getting. That debate, I'm not sure of whether health is public good or it's a private good. There are those who would say it's a public good. There are those who would say it's a private good. And it is understandable. We can't all agree into one thing. But COVID has shown us that health can be of public interest when the time comes. When the whole world came to a standstill, it was a disease. So you could have easily said, you na COVID yako weka kando. It's your own problem and it's none of our business. But it became our business in as much as it was from another country, not even something that has started locally. On the issue of the input of KMA, I think my president, we will be here 9 months from now, and we will see the input from KMA at the board level. And we will be discussing how so far we were in terms of that input and the difference it will make, which we don't doubt. But it's not that KMA needed to be at the board level for it to contribute. Because these laws and everything was done when there was no even board. Regulations were done when there was 2 or 3 members at the board level. So I don't believe in you can only contribute to something when you are a board member. You can contribute even when you are outside. So the issue of saying it's not us, there was the option of saying this was not us. We don't want to be appointed. Please look for another association to sit on that seat. That was also something that you could easily have taken. I'm happy Kush have spoken a lot, and actually he has made my work much easier. So Kush has explained the different models, and this is what we need to understand, that there's no one size fits all. UK does its tax system, NHS. if you ask the people who live there, patients, individuals, I know Kenyan doctors who work in NHS in the UK, but come to Kenya for treatment when they need major surgeries and when they need surgeries and such. When you ask them, they will tell you that system is bullshit. Sorry, my French. But there are people who look up to that system and say, oh, it's tax funded, it's good. So that tells you there's no perfect system and there's no perfect financing mechanism. Then we talked about Netherlands. Netherlands insurance is mandatory, same as SHA. But what you need to realize is what we are looking at, what is our yield? How much are we collecting? Uh, are we able to push that limit? Yes. Increase the rate from 2.75% maybe to 10%. What will that give us? It will give us more money. Are we able now to increase the benefits and the tariffs? Yes. Are we able to increase the cesarean rate? Yes. It all depends on how much more are people willing to contribute, or how much more are we going to get from the tax fund. So for us, we have done the mixed model, contribution plus tax. It's just to lessen the burden on individual contribution, but have something extra, at least from tax, to balance it. Because just allowing it one source of funding was very difficult. Of course, the US has moved the private insurance. Ask around anywhere in the world, you will be told the US system is the worst because it is what my friend Eboso is advocating for, that health is a private good. Let everyone deal with their problems, whether they like it or not. But unfortunately, despite that, the US spends the highest amount of money per capita compared to the Scandinavians and the other OECD countries. So you then realize that privatization without government intervention will just kill the health sector fully. And it will be very unsustainable and very catastrophic for majority of the people. Even in the US, if you look around and read around, look for that documentary called Sicko. You will see how Sicko, SICKO, you will see how bad that system is, of where you say this is private good, let everyone pay, and then let everyone take care of themselves. Finally, the issue of Robin Hood or the rich should pay less, that is now, another debatable issue. So if the rich pays less or pays less rate, then the poor pays more. So who is funding who, and who is benefiting more than the other? So those are, for me, as I have said, is the debates now that need societal debates, social hall, where we have this discussion and discuss what kind of contribution and whether something is public good or private good, and how do we handle the financing mechanisms. I think I have touched. If I've forgotten anything, we will have another session as usual. But this time round, I'm sure we will not be discussing the basics. We will be now delving into other issues. On the issue of transition, yes, we have faced challenges. The challenges we have faced is mainly the system, and we have delayed in communication to the providers, because generally it's providers who, and it's all because of the mistrust that they have had with NHIF. We all know a system does not treat patients, it's hospitals and healthcare workers. But because of that lack of mistrust between NHIF that has built up over the years, that's where now there was a small challenge in terms of the communication reaching and releasing that communication as early as possible. That if you have a challenge with the system, please use manual claim processing so that patients get services as expected. So yes, I'm not dismissing that there were hiccups. There were many people who had difficulties in accessing services, and it's not that it's an easy thing on our end to say, it's a small matter. No, nothing is further from the truth. So yes, we are owning up. We are not saying, and we are not burying our head in the sand to say everything was smooth. Far from it. But we hope to complete this transition by the end of next week. We will have finalized, and every facility would have been onboarded, because I was looking at the dashboard as late as right now while we were discussing this issue to see how is the consumption, how is the logins from the providers. And I can assure you, majority of the facilities, total providers enrolled is around 6,900 facilities have already been onboarded. So we will continue monitoring to see that we transition everyone as much as possible. And I just want to reassure providers that we will make sure even the old claim system, e-claim system that was closed, we will open it up and conclude that process once we fully take over and recruit new staff. Thank you very much.
Thank you, Dr. Abdi. Thank you for giving us your time tonight, just to clarify on the questions that you might have. We wish you and your team all the best, especially during this transition period, as it's mostly the patients that are affected, and they usually need services to go on during this time. But I just wanted also to end with you'd say that the hiccups are also usual, but it would also be remiss not to mention that we usually use this, the road to hell is paved with good intentions. So however good they might be, we need to look at the transition. You'd also recommended that by, I think we can hold another one by November 2024, which I'll follow up keenly with Dr. Mbiti. So just so that we can just put you to task, especially since you've said the system will be fully operational by November 2024. And another thing, just before we end, I know you'd said mostly about being it employee-based, but kuna watu wa bodaboda NTSA, polisi wameshindwa nao. Sijui kama you and your team mtawezana nao, especially getting contributions from this sector, especially since they're the informal sector mostly. But thank you for your time, and thank you all for tuning in and listening. Hope some of your questions have been answered. The next time we hold, we'll try to keep it short or be more specific with the questions. But it's a learning curve that we're starting with right now. So hopefully we'll have a better, more fruitful discussion next time, where we'll have more questions, especially from our listeners. Thank you all, and have a good night.
Yeah. So thanks again, once more. I appreciate you, Share. Not everyone takes 3-4 hours late into the night to have these conversations. We'll definitely have a follow up, like Nigel has said. Thank you, everyone. Thanks, Chair. Thanks,
Thank,
the speakers.
thank you, thank you, thank you, thank you, thank you very much.